spoke later afternoon. All right, excellent. Okay, in the interest of time, the time is 10:01. We'll start. Thank you everyone for joining. This is our AMC clinical exam session in which we're going to be doing cases. Obviously, people will keep on coming and I'll keep on adding them because obviously punctuality is on the top of priority of everyone. And, we've got Dr. Junaid, we've got Dr. Gulna, and I'm not sure if Dr. Farwa is already there, but she'd be joining us shortly as well. All right. So basically how we're going to do the session is we're going to talk about how to plan your AMC journey. And I'll get Dr. Junaid and Dr. Gulna's approach and we'll talk about the history because that tends to formulate 70 to 80% of the cases, the diagnostic formulation from the history, examination, and management options. So what can we do in order to optimize our history taking? Then we'll talk about some of the communication keys. I think there's some sort of misunderstanding. There always is about communication and how can we, improve our communication to have a better idea as to what's happening. Does it make sense? Makes sense. All right, just give me a second. Okay, perfect. We'll do some cases and we've all got cases for you. They're slightly atypical. The cases that I've made today they're a little bit complicated. So I think it'll add a little bit of spice and flavor to the usual things that you tend to do around from here and there. So I would please request anybody and everybody to come and participate. It's all a very friendly session. You're not getting judged or anything like that. It's about your chance of making mistakes and learning from them, because I think for me at least, learning makes mistakes make me learn. And if I can learn from my mistakes and they stay with me, there's nothing like it. We'll talk about a few of the things to avoid and finally open up the pod for question and answers. Any questions at this stage? No. All right. So Dr. Gulna, tell us something about yourself.
So hello. First of all, my name is Dr. Gulna and I'm an international medical graduate. I have done my MBBS from Pakistan, from Peshawar. I'm basically from Peshawar. I have done my MC Clinical recently in August. It wasn't my first attempt. It was my second attempt. I failed my first attempt with 9 stations in February 2022, this year. And the second time I was a bit more confident. I knew the worst thing was to get failed, right? It has already happened to me. So I always used to think that, no, this time I want to pass my exam with very good marks, not just passing it. And I was very empathic and I was very, I took the role players as real patient. I made sure that first of all, I make sure that they are comfortable before starting with the history taking or before starting with the station. And I think that was really good because in one of my station, the guy, he was having a back pain, but he was he was a very, very mean person. He even said that, doctor, don't ask me for the medicine, do what you are being asked to do. He was very mean to me. And he was in my first exam as well, the same guy.
Oh,
so
dear.
I remembered he was a mean guy. So I made sure that I talked to him very nicely. I made sure that I make him comfortable throughout. And towards the end, he was even smiling and was saying, oh, thank you, doctor. Thank you so much for that. And I knew that he was a mean person. If he's happy, then this means that I'm doing good. So I think the main thing is that we should take these role players as real patient, and we should be very empathic towards them as well, because the real patient, they are having real pain and they're having real issues. And secondly, regarding the PED station, I think we should always first go towards the parents and make sure that we reassure them that your child is stable, he has been taken care of, we are taking care of him, he's totally fine right now. Let me ask you a few more questions so we can make a management plan for him. It will just take like 30 to 40 seconds extra, but it makes a lot of difference towards the end. You always get good marks in the approach. So yes, I think that was the difference between the first and the second attempt.
Yeah. And it's always in pediatrics, you're not treating just the patient, which is a pediatric patient. You're also treating the parent. Dr.
Exactly,
Junaid, good morning, sir. How are you? Now, I really appreciate you've been post-call, and Dr. Junaid was just telling me that he's post-call. He's been driving back and forth from I don't know where, and he's joined us from Pakistan. So Dr. Junaid will be doing morning sessions with us in AMC Clinical. So how's life? Tell us something about what's going on.
Life is good. Life is good. These are
Has the
like
light
perks
just
of
gone? Is it
Pakistan.
as a
Yes, yes.
all right? Okay.
I'm waiting for the generator to kick in. Yeah.
Okay.
So yeah.
There you go.
Yeah. So my name is Junaid. I am an international medical graduate. Currently, I'm doing my residency here in Peshawar in neurosurgery. I have started my AMC journey quite earlier, like in 2018. I was planning to give my AMC clinical in 2020, but because of COVID, it got delayed for about 1.5 years. And in the meanwhile, it was quite difficult for me to travel to Australia, so I opted for the AMC online one.
Yep.
I appeared in September 2021, but unfortunately, I could not pass. I failed with 9 stations, and then after that, I was lucky enough to get another date in July 2022 this year. So I passed my clinical exam, though I was very scared that I'm going to fail this one too. But luckily, I passed with really good scores. And the good thing is that I know that how I failed my first one and how I passed my this one. So I think this would be very helpful for the candidates so that they can they would learn that what mistakes to avoid and what things to do. As Dr. Gulna already said, that approach is really important because you make the patient comfortable. You talk to them that, yeah, I understand that you are in this must be difficult for you and you're going through a difficult time. So they actually open up. They talk about their complaints easily.
That's
you
right.
do not have to dig and they would voluntarily give you all the information. And always try to be a safe doctor. Like you, if you are having limited knowledge about something, but if you are a safe doctor and your approach is safe, you are involving your seniors, because this exam is like at the level of an intern, right? So they are not expecting much from you. If your communication skills are good and you know a little bit about the topic, so I think they would pass you with really good scores.
That's a
There is
good
no
point.
need. Yeah,
That's a
there is
good
no
point.
need of going after the theory that much.
Yep.
You should do more
It's
role
all about
plays.
practice. Yeah.
Exactly. You should do more role plays, which we are focusing in emergency focus.
Yeah.
So I think this would be really good for the candidates. Yeah.
And
So
the other
that's
thing,
pretty much.
the other thing which Junaid and Dr. Gul and I have already pointed out, it's not failure. I don't say it's failure. It's about being not successful. So all of these
Absolutely.
postgraduate exams, the licensing exam, the fellowship exam, the membership exam, they've got a certain standard. Otherwise, if they pass everyone, then obviously it'll become a very easy step. So in order to, treat it as a next big step in your professional career or life, they create a little bit challenging. So they set a standard. And obviously, if you're not meeting that standard at that point, doesn't mean that you're not going to meet that standard forever, but you need to meet a certain level of standard, which is an expectation in
Absolutely.
terms of your professionalism, communication, and obviously, everything comes back and forth. Now we've got Dr. Farwa. She is uh, been doing our evening sessions for quite a while. Dr. Farwa, good morning, madam. Thank you for joining us.
Good morning, sir. Good morning, sir. Good morning, everyone. Hope everyone is doing well.
How's it going, and what are your takes on AMC?
First of all, sir, can you please give me a second? I'm so sorry. It's
that's
someone
okay.
on the door. Yeah.
That's okay. Someone's on the door. In between that time, so as I said, that it's about meeting the expectation, what they have, what the examiner has gotten point. And these are obviously the red flags or the critical errors, which are important. And we need to make sure that we are not having, and Dr. Junaid, I like your point. When you say that this exam is pitched at an intern level, I personally believe AMC 1 or AMC 2, in fact, is a very easy exam. It does not require the depth of information, but it does require a diversity in your clinical skills and your communication skills. So it's important that we are able to communicate them well. And being a safe doctor, and we'll talk through some of the clinical scenarios today, how to be a safe doctor and how to go about it. So in terms of planning, I'm not going to beat about the push. Obviously, everybody has got their own plan, but I sort of advocate pass all 16 stations, including the pilot stations. no matter like, you may not even know what the hallucinations are, but if you aim high, then yes, you get good. Isn't it, Dr. Farwa? If you aim high, you get good.
Yes, sir, it is like this.
Excellent.
Yeah, I'm so sorry, sir, for the break.
No, don't apologize. That's okay.
Yeah. So my name is Farwa. I'm an international medical graduate as well. I cleared my AMC clinical exam last year, and it was an online exam. I was lucky enough to clear it in a single go. But it's just like what I have learned from the whole experience and everything is like, sometimes you need to kind of, you think that you can wholly and solely rely on, your classes and everything. Tutors can guide you up, help you in building your approach. But at the end of the day, you need to practice. If you are not practicing and you're solely relying on the academy, it's just like no matter how good you are, how good the academy is, how, sincerely the teachers are teaching you, you would not be going anywhere.
Clinical, AMC clinical.
Yeah.
All right.
Yeah.
Okay. Yep. What else?
Practice.
What have you found the common mistakes that the participants are making? Obviously, you've been doing these sessions with us for the last so many months now.
Yeah.
What seems to be the common theme, commonalities?
So basically what I have felt is like, number one, communication skills. It doesn't involve the language, knowing about the language, but it also involves the appropriate usage of words. That, if you're breaking a bad news to a patient, your expressions should show that you are being empathetic. Right? And you should be very carefully using your words, because at that time the patient can, explode on you over every little thing, right?
Yeah.
So you need to be kind of, very mindful of that. The other thing is confidentiality in certain cases. This is very important. Sometimes the patients don't tend to open up, even with one-time confidentiality established. So in those cases, we need to establish double confidentiality, just make the patient as comfortable as we can. And the third thing is like, sometimes in the, while preparing for this exam, we get into so many of complications which are just not required. Like the dosages and everything, it is just not required. Sometimes even if you say, okay, I will be putting this patient on an antibiotic, even that is fine. They are judging you as a junior doctor, right? You have to escalate. What they are looking for is like, are you a good team player or not? Are you escalating it to your registrar or not? Are you giving the first line treatment appropriately or not? Every basic thing which is required, are you kind of, addressing those basics or not? This is something which is important. Yeah.
Perfect. And I think that's a key here, which is not only worth understanding, but actually imparting that in terms of when you're playing role. Is that to develop a rapport and be empathetic? And we'll go through some of the issues into how to taper on, or to how to sort of adjust your rapport building, because again, there seems to be always a little bit of confusion around the certain communication aspects of it. So as I said, aim high, follow routine, which you can follow in terms of having a repeatable but regular routine in terms of preparation. I think 3 months more than enough, but if you've been preparing for a long time, that's up to you. 3 months of dedication will get you anywhere. Trust me, you can even pass the Fellowship of Emergency Medicine or ICU exam. But then again, if you are not very well prepared, well disciplined, or discipline is the right word, not preparation, discipline, then even 1 year, 2 years, or 3 years are not enough. Now, I often advocate to practice in the real exam condition from day one. If you put yourself out into an area which is an exam situation, you will not feel naive or indifferent when you're doing role plays. So why not expose yourself, put the timer up, say, I'm going to do the scenario. This is my base level knowledge. I'm going to extract everything from my base level knowledge, see what my deficiencies are, and then improve on that, and practice and practice and practice. This goes regardless of any exam. Practice is the key. It exposes the areas which you are not very well versed with. Do as many scenarios, attend as many sessions. Role plays are the key here. In fact, I think your learning should be directed with the role plays. You should be learning everything through the role plays. The way that you integrate your communication skills in each role play becomes a part of that learning process. So if I was to put a number to it, if you can prepare 300 role plays and you can modify the slight variation of each of them, you can pass this exam dead easy. All right, so let's move ahead. I'll basically give you an approach. We tend to advocate for that approach in our exam. First of all, obviously, it's an exam which involves reading the task and then reading the question, which is your scenario. So I often advocate, and I think all of you would agree, questions or scenarios can often be very long. Start off with reading the task first. And the whole key idea behind that is to come up with your differentials. Not even the diagnosis, just the differential. What could be wrong? Is this a patient who has got, chest pain, which is an acute myocardial infarction, acute coronary syndrome? Is it a PE? Is it a aortic dissection or anything on those lines? If you've got enough differentials, then it will pave your way when you're doing the session in next 7 or 8 minutes. Then when you enter, obviously introduction, comfort, consent, and stability. Now that's the key. And I want you to pay close attention. I am sick of formulaic approach. The people who are coming to do the sessions is they just use this very robotic approach. There is no repo and empathy, or there's nothing. Try create a variation, individualize your experience with a patient. Okay, there is nothing like coming. If the examiner, or even Dr. Farwa has shared, Dr. Junaid has shared, and Dr. Gulna has shared as well her experiences, that the patient were very frustrated because obviously they're doing that with I don't know how many candidates a day. So I remember I was preparing for the emergency fellowship exam, and I had a colleague of mine who I was preparing sessions with. So we were going and seeing patients and for fellowship. His name was Peter McKenney, and he was an Irish fellow. And I used to think, man, his knowledge is so basic. I don't know how he's going to pass the fellowship exam in emergency medicine. But he had a trick up his sleeve, which I did not know. And that trick was that he used to completely personalize. When he was going and talking to the patient, it looked and felt like he's talking to the real patient. Okay, I'll give you an example. Something like there was a pregnant lady. There was a scenario about a pregnant lady who's come in with abdominal pain and some PV bleeding. And he started off by saying, "Oh, so your name is Sarah. Sarah, I'm sorry to hear that you've been experiencing some problems. Pregnancy is a strange time of your life. Both happy, obviously, because of the upcoming baby, and obviously it can be associated with so many changes in your body, so that can be challenging as well." I said, "Man, that is great. Like, how do you fit that all in?" And that was a part of rapport building. If you can use these kind of little tricks, it just does not take, it takes less than 5 seconds, but it helps patient volunteer more information. And we'll talk a little bit more about that. So rapport building, history, examination, investigations, then go on for the plan. As I said, diagnosis and differentials. Management, I talk about general, specific, disposition, follow-up, and counseling. So general management is to stabilize patient condition, offering him analgesia, giving him oxygen if the oxygen saturation is low. Specifics, obviously treating the underlying condition. If he's got an underlying, pulmonary embolism, if he's got an underlying bowel obstruction, if he's got an underlying issue which needs to be rectified, then that is the specific treatment. And if you even think about that, you will not miss any of the red flag or critical errors because you're organized. All right, you're not forgetting analgesia, you're not forgetting the specific treatment behind it. And then obviously disposition decision, whether you're going to send this patient home, admit the patient, whether you're going to follow this patient up in 48 hours, 72 hours. That's exactly what we do on the floor at all times. We've got Dr. Pereira here. I am not sure where, Christine Pereira. Yeah, there we go. Christine is here. We were working on the floor yesterday, actually. And thanks for joining. It was, I hope you finished on time, Dr. Christine, last night. It was a busy.
Yes, yes.
All right. Okay, so let's just go through this case and then we'll do a little bit more in detail. And I'm happy for you to interrupt and stop me at any point. Christine, we'll just do that as a group exercise. I'm not going to get to role play or time it just as bad because I think Dr. Farwa and Dr. Gulna and Dr. Junaid has got plenty of sessions for you to do. So Mrs. Reagan, a 72-year-old lady who's presented with to the hospital with the right-sided toothache and mandible swelling. In the last 2 days, she's noticed a lump and developed on the left side, which is developing on the left side of her face, I should say, slowly extending toward her neck, I should say. So my apologies. The lump is painful. Okay, so 72-year-old lady who's had 4 days of right-sided toothache, mandible swelling, and is getting worse. In fact, I have done this scenario completely bad. It's actually left-sided swelling, if you see. So it's a left-sided swelling, my apologies. So it should read, Mrs. Reagan is a 72-year-old lady who's presented to the hospital with 4 days of left-sided toothache and mandibular swelling. In the last 2 days, she has noticed a lump develop on the left side of her face, slowly extending towards the neck. The lump is painful. These are the vitals: a slightly tachycardic to 102, temperature of 38, blood pressure is stable, SATs of 99. Your tasks are to take history and then come up with the possible diagnosis and differential. Now, you 3 minutes which are outside or perhaps in an online format, they're your time to get organized. What do you think would be the differentials here? Anybody? Let's just do that as a group exercise. Just throw it out there quickly. Come on, guys.
Yeah, so I can think first of all for abscess because temperature
Yep.
is high and the patient is tachycardic as well.
Yep. Excellent.
The cyst can be one of the differentials.
So abscess is one important thing. Cyst, yes, it could be an infected cyst. Anything else?
Lymphadenitis.
It could be some lymphadenitis, but obviously it's a, if you look at the picture, it looks like that it is quite erythematous. There's some spreading cellulitis and there's some weeping going on. Can you appreciate that weeping?
Yes.
All right. Okay. So think about the lump in itself. It could be an abscess, but it is not enough to just say an abscess.
Yeah.
I've given you an information, just link it up. That this could be a dental infection which is now spreading and causing an abscess involving the mandible, which is now presenting itself with a skin infection on the exterior.
Yeah.
All right. Or it could be a facial infection from a wound or a lesion or a cancer which has got secondly infected. So just opening up those words and differentials to have a variety in your thought process. But that's excellent. It could be an abscess, which could be from, underneath and coming out, or it could be a skin infection, which is from out spreading towards in.
Yeah.
But
or
she
can
has,
we add here herpes or vesicles? Yeah.
well, I can't see any vesicles, but that could be one of the differential because of the facial redness. It could be like any facial redness differential. You just need 3 to start off with, but these 3 should be good.
Yeah.
All right.
Sure.
All right. So in terms of the history, what would be the key question you'd like to ask from Mrs. Reagan?
Yeah.
Just
So,
very quickly.
yeah. So we can ask her that when it started and
Yep.
was it suddenly or gradually?
Yep.
And yeah, is it this? Does the size is increasing? And is it painful, itchy, oozy? And of course, the fever, if
Yep.
there, and is it the only lump?
Yep. So that's what's important, obviously. But before you start, obviously, you need to have that systematic approach that we were talking about. You need to start off with your introduction and comfort and consent and stability. Okay. So remember your basics. As Dr. Junaid and Dr. Farwa said, it's all about having to have yourself assessed. And I'm pretty sure you'll do that in a real scenario. I'm just saying that even if I put you in a hot seat, just don't let go of your basics. So always start with the introduction and all that. Okay. So introduce yourself, check the comfort level, consent. By the way, this is the real patient that I saw in emergency department. I've used a picture. I hope that patient doesn't find out that I've been using her facial pictures and scans for my learnings. Okay, so always introduce yourself. Like, my name is Rizwan. I'm one of the emergency physicians. My name is Rizwan, one of the doctors, and I can understand and see that you're quite visibly distressed with this large swelling. How about I offer you some analgesia to make you comfortable, and then we'll start with some questions. So create that personalized experience from that point of view. And are you allergic to anything? So I can use some stronger painkillers. Looks like that it could be quite painful. So my preference would be to use Panadol and ibuprofen. As Dr. Farwa said, it's not about the dosage and specifics, but obviously mentioning some sort of analgesic name would put you in a command to that situation. And then obviously, as a part of this, I'll be asking some of the questions which might be intimate, which may involve the aspects of past medical history and drug history analogy and social aspects as well. Hope that's all okay with you. Let's start. And yes, you're right, Dr. Amber. Then you will go on about the swelling in itself. And Dr. Farwa has got a very good approach about these lumps. Dr. Farwa, what would be the key question in terms of swelling looking like that? Would you advise?
Yes, sir. So starting from, first of all, rapport forming, I would be kind of, asking the patient that, okay, from the notes I got to know that you're having this right-sided, for example, left-sided lump. And can I ask you, since how long you're having it? I'm so sorry to hear that. You must be going through a
Very good.
lot.
Yeah.
It's like that, and I am a bit concerned about your symptoms. So I would be kind of, shifting you to a monitor day so that I can keep an eye on your vitals while I take history from you. Is that all right? Then go forward where exactly the lump is. Okay. How big it is. Okay. So can you move it, or it is just attached to the underlying structures?
Yeah.
And how about the overlying skin? Can you see any redness around it?
Yeah.
Can you see any skin coming out of on that particular area? Can you see any oozing
Yes.
from that particular thing? Does it bleed? Is it painful? If it is painful, then anything which makes the pain worse or better. And is it painful all the times, or or when touched, or any specific time? Associated features would include all your differentials. For example, here, particularly, I will be concerned about fever associated with chills and rigors. And then during the course of it, I would be asking about, like, by any chance, is it interfering in your, usual routine? Like, is it trouble, chewing for you, or
that's it. So aerodigestive
yeah.
symptoms, like any
Yes.
swallowing issues, any stridor, because it is very
Yes.
close to the airway and breathing and swallowing
Yeah.
mechanism. That's perfect.
So basically, you have to explore the symptom, try to know about the cause as well as the complications it can do.
Perfect. So in terms of the past medical history, if I was to say, now this is for any other candidate, what would you ask in terms of past medical history? I'll tell you some of the past medical history. This is a lady who's got a background history of rheumatoid arthritis. She's also got an osteonecrosis of the jaw. And I'll tell you in a bit what osteonecrosis is. She's got an asthma. The medications that she takes, she's on prednisone 25 milligrams daily, methotrexate 200 milligrams daily, hydroxychloroquine daily, and morphine patches. So can I just ask any candidate, what does that tell you now? A patient who's got rheumatoid arthritis, she is on a bunch of medication which includes prednisone and methotrexate, and now is presenting with this lump which looks wavy and she's febrile. What does it tell you?
That she's immunosuppressed.
Very good. Excellent. So this patient is immunosuppressed. Excellent. So the diagnosis and the differential diagnosis are very important for a patient who's immunosuppressed and presenting with a fever. Obviously, it's a time critical emergency. So whenever you're taking the history, as Dr. Farwa has already sort of brushed on the key aspects of presenting complaint, how long have you had the lump for? How's it grown? How the pain has been progressing? Is the pain getting worse? Have you been taking anything the pain? Has it been helping? Is swallowing an issue? Is breathing an issue? Moving on. Do you think it's spreading towards the neck? Is movement of the neck any painful? Because the neck and the mandible, it can give Vincent's angina, Ludwig's angina, and things like that. So you have to consider all of these aspects. Then have you noticed any lumps in your neck as well? Like what we specifically hoping to ask for is any supraclavicular or cervical lymphadenopathy. All right. And then obviously, if you've had this kind of problem before, now this is a very important question. I don't know why we don't ask this question. have you had this problem before? Patient presenting with abdominal pain, chest pain. Have you had it before? And what happened at that point? This will not only save you time, but actually completely give you a very focused information in a very short span of time. So that's all. You don't have to go and dig a lot out in present illness. Obviously, time is of the essence. You need to jump onto the past medical history. Okay, tell me about the way I've actually started to do, even in my clinical practice. I said, can you tell me about what your past medical history is and what are the key issues that you take regular medications for? And the patient say, oh, I've got diabetes, I take insulin and metformin for that. I've got asthma that I take Ventolin and Trilogy for that. And I've got hypertension that I take, amlodipine and Covisil for that. So that's a more economical way. You need to tick off that box because the task does say take history, and history does involve presenting complaint, history of present illness, past medical history, drug history, allergens, social history, everything. So you must touch base on every aspect, because if you miss some aspect, it may have that vital information which you'll miss. Moving on. So social history, lives with the family, fine. Non-smoker, obviously smoking would be important. In case of malignancy, they get oropharyngeal cancers, tongue cancers. So that's all very important. Rheumatoid arthritis. Okay, so if you've suffered from rheumatoid arthritis and she's telling you that she's osteonecrosis of the jaw is basically like an avascular necrosis. Remember the term, like when the fracture neck of femur happens, intracapsular, and the blood supply cut off, they get an avascular necrosis. Osteonecrosis of the jaw is the same thing. Rheumatoid arthritis, methotrexate, it is actually a cause of that in this patient. All right, so that is a vital clue. This swelling and recurrent infection are not going to get treated easy. So moving on. So my key differentials after asking all this information, I'll summarize it in my mind. So this is a lady in middle age to advanced years who has got a background history of methotrexate for rheumatoid arthritis, previous history of osteonecrosis, and she's on prednisone and methotrexate. She's already immunocompromised. She's presented with what it appears to be a facial cellulitis plus an abscess with an active weeping. So that's my key issue here. She's got a facial abscess and she's got an underlying mandibular osteonecrosis. So that's very likely that that mandible bone is osteomyelitis. And why is it osteomyelitis? Because its vascularity is not there. It's no longer vascularized. Vascularity is good. It sends up the neutrophils and macrophages, fight the infection. She's obviously not got that. So this is a long-term problem for her. All right. So this is my differential now. Facial abscess, cellulitis, underlying mandible osteomyelitis, and obviously there could be some other issues, like could it be a skin cancer with secondary infection, as we said, or could it be underlying dental abscess even, because it did start with a toothache. And that's it. It often does not take a lot of information to pass the station. This is obviously a very quick abridged version. We've just done a lightning session on it, but that's the key highlight which I wanted to share. Now, whenever you're taking a history, obviously, as Dr. Farwa was saying, introduction, confirm, correct. No matter, even if somebody wakes you up from sleep, don't forget your basics, that you must introduce yourself. You must make sure that your rapport is there and you've offered the patient analgesia if the scenario involves a pain management issue. Screening of symptoms is important after taking your history of present illness in terms of any other coexistent symptoms, the chest pain, abdominal pain, shortness of breath. It's just a quick rule out. For example, with this patient, I may just ask, have you got any other constitutional symptoms? Have you lost weight? Have you been having sweating at night? Have you been having rigors? Okay, so these are those leading questions which are somewhat specific to the scenario, but you can just add them quickly at the end. Yes, Dr. Junaid.
Well, actually, as you said, that we have to dig the history in detail, because in every station there is actually a predominant assessment area. So in these kind of scenarios, if you see there is actually a history task, and then you have to tell about the diagnosis and differentials. So as you said, that we have to touch on all the aspects of the history. That is really important. You shouldn't be thinking that, okay, I can leave this and I should be talking about that, because most of the time you would be getting about 5 or more minutes for the history. So your history should be very in detail. You should be talking about the past medical, surgical history, any procedures that the patient had.
Yeah.
And every station has this predominant assessment area. So if you pass this predominant assessment area, there is a high chance that Even if you get like a 3 in the other domains, you will pass the station.
Very good. Very good point. All right. And obviously it's about gathering question. I'm going to draw a parallel with my practical life. Like when I go and see the patient, I just say that, look, okay, after the introduction, look, I'm sorry to hear that you've come in to the hospital with this problem. Can you tell me a little bit more about it? Now, this is just 1 minute given to the patient to just throw it out there, open-ended, non-leading question. And trust me, this is a good substrate to start off, because then you can nitpick on the information that, okay, fine, she's come in with the mandible pain. She'll tell you all about, look, this swelling's getting worse. This swelling is now weeping. The pain is getting worse. Some problem chewing. I'm getting night sweats and rigors. And then you can nitpick on it. So this is actually patient saving time for you. You don't have to go and ask these questions repeatedly over and never repeat yourself, please. Sounds very unprofessional. I know in the heat of the moment and anxiety, you will be asking the same questions, but that often happens when you've not prepared the scenario well. You ask and repeat and waste time and look thoroughly unprofessional. Don't repeat it. The information that you've been given, utilize that information and so save and store it in your mind. Okay, because that forms a partial differential. So open-ended question, listen, closed questions. Obviously, in terms of what we've already gone through, site, onset, character, radiation, you all know Socrates. Now, I tend to summarize at the end. You may or may not have time. So look, correct me if I'm wrong, Mrs. Reagan. I believe that you've had this swelling for 4 days. It's getting bigger. It's getting more painful. It's weeping. And you've got an underlying rheumatoid arthritis and jaw problems for which you're on prednisone methotrexate. Am I right in assuming that the concern right now is recurrent infection? Just that summary. Am I missing anything here? You need to create this sense of real life interaction. You can't just, appear robotic, because if you do, you'll miss out on things. I remember when I was doing my fellowship OSCE exam in Melbourne, and by the way, it was an AMC center as well, the fellowship exam. I was so involved and engrossed in those cases, I almost felt like, I'm going to hear an alarm as an, emergency announcement. Dr. Rizwan to room 4, there's an patient waiting. So be that much involved in your case that it looks and feels like, some of you, obviously, you might not have practiced for a long time, but that's the level of engagement and involvement you must have. All right, I'll jump on patient perspectives. That's important. There's no harm in asking what the patient thinks is wrong with them. What is your expectation today? Now, that may or may not be something that you would like to use in every scenario. Okay, but there's no harm in saying, okay, fine, this is my understanding. Have you got any realistic, what is the main concern here today? So the word is concern. So we've taken the history, Mrs. Reagan. I believe you've got this lump and swelling and infection. What is your main concern here? Well, my concern, doctor, is that I need to, the pain is getting worse. I'm very worried because my chewing is also getting worse. I'm not able to eat and drink now. And okay, fine. Now it tells you that you need to focus, because she cannot eat and drink, on her nutrition, on her IV hydration, plus the analgesia, plus the specific symptoms of treating the underlying infection. So that is the key here. So there's no harm in adding that. So this is a unique perspective I'm giving you right now. These are some of the very personalized things. I was thinking last night when I was driving from work that what can I talk today which will layer up and try bake you away from your formulaic approach to a more personalized approach. All right. And trust me, like Dr. Junaid, Dr. Farwa, they look like they're very innocent, but trust me, they're not innocent. They've all got their own tips and tricks up their sleeve, and they look very personalized when they're doing their session. So don't be misguided by their cute, innocent faces. They have got their own tricks up their sleeve. So you need to be better than them. Okay. And you can do that. All right. Anything else, Dr. Gulna? Are you okay? Anything, word of wisdom that you'd like to add? And then we'll jump on to the scenarios.
Yes, that's it, I guess. And I just want to add that you need to be very much empathic and support and everything. Yeah, that's the important thing.
Perfect.
And yes, the important thing is that sometimes we get some questions like, patient presents to you having, you don't understand what the patient is having. Like English is not our first language, right? For example, the patient presents to you with funny turns. So there's no harm in asking them, what do you mean by funny turns?
That's a good
You don't
question.
have to assume by yourself that, okay, he's having or she's having this
Dizziness,
thing.
yeah.
Yes, if the patient even presents you with unwell, so just ask him, what do you mean by unwell? They will sometimes tell you that I have fever, I'm having this tiredness, or sometimes, like most of the times, these are the two symptoms represented when they are feeling unwell. So yeah.
Perfect. And this is a very important point, because even, there's several different ways and interpretation of the word dizziness. For some patients, it is like vertigo. For some patients, feeling giddy or lightheaded. For some patient, it might be even having some sort of headache. So please get them to explain to you in simple words, what do you exactly mean by dizziness? Okay, and keep in open. Okay, I'm going to jump in and do a case quickly. And obviously, look, I have taken a slightly atypical approach. And these are the cases which I find interesting. Obviously, I try to layer up with new cases all the time. And if anybody would want to volunteer, please go ahead and do that. This is your chance, or forever hold your truth. And if you do that scenario here now, trust me, exam is going to be like a walk in the park. Who's going to volunteer? Oh, absolutely. Good. Go for it. I'm not timing you, so go for it. Would you like to read the scenario?
Can I get just a few seconds for just reading it?
Absolutely, Amber, you can. And you can start by reading the scenario.
So, okay, 7-day-old baby boy has been brought to GP by his first-time anxious parents with complaint of rash on his body. The rash developed 3 days ago and gradually been spreading. The baby is well otherwise. So the vital signs are 130 heart rate and SATs are 100%, blood sugar levels 4.2 and temperature is 36.1. Weight is 3.9 kg and the birth weight was 3.5 kg. I have to take a history from a parent and I have to explain the diagnosis and outline the management.
That's it. I know it's a lot of thing, but yeah, I know it's challenging. I should have just stopped explaining the diagnosis. So even if you explain the diagnosis to me, we're fine with the management aspect. But if you can touch base on some management areas, that's fine as well. And I saw this case last week, actually. And this is, again, a picture from a patient taken from my iPhone. So I try to use as much as real life scenarios and convert them into an AMC scenario, so you get a bit of a more real life flavor to it.
Yeah.
So I'll be the parent first time, and you can be the doctor.
Right. So hi, good morning. I'm Amber, one of the doctors here in this GP practice. How can I address you and your child?
Oh, so my name is Rizwan, and this is my baby, Tracy. And, she's been having this problem, doctor. I'm very worried about it.
Okay. I can understand, Rizwan, your concern. Being a parent, you must be very anxious at the moment because your child is not well. So let me assure you that I'm here to help you out, and I will be trying my best to take care of your baby. And for this regard, I need to ask you a few questions. Will it be fine with you?
Yes, doctor, that will be absolutely fine.
Yes. So Rizwan, I just want to check the vital signs of Tracy, that whether she's going fine, and then we will be continue with the consultation. Will it be fine?
Yep, the vital signs are on the screen. As you can see, they're the latest ones.
Okay. So Rizwan, can you tell me that from how long you are feeling the child is not well?
Yep. So doctor, I noticed she's only 7-day old. In fact, he's only 7-day old. He's let's call him Jimmy. All right. He's only 7-day old, and he was born normal, quite happy baby. Didn't really have concern, feeding well. On about day 2, we noticed these small spots, doctor, on his body. And I'll just bring the screen and make it a little bit. And they had like these small whitish points on them. And we started to notice them. They were coming on day 2. And by about day 3, these were getting more and more on the chest, and on the lower part of the belly, and also in the groin area. And we sort of very got concerned as to what's going on. He looked fine,
Yeah. Yeah.
but then they tend to get bigger and they get redder, and sometimes there's a discharge coming from there, like a clear golden sort of liquid coming out from them. And that's what I got concerned. And I saw the GP and he said, you better go to the hospital.
Yeah.
It could be infection of some type. So
Yes,
that's why, doctor,
Rizwan.
I'm here.
Yeah, you did a right job and bring Tracy here. So I can see that at the moment he doesn't have any temperature, but as you are saying that these rashes are getting worse day by day, and this is the thing which makes you more anxious. So can you tell me that is he eating well?
Yes, he's been feeding. He's breastfed. Same amount of time he spends on each breast, same amount of milk he takes. He's actually put on weight, doctor. So
Right.
apart from these rash, he's not really behaving in any way. Even though, look, we have the first-time parent. Obviously, we are very concerned about it. But he doesn't seem to be upset about anything.
Okay, and right, and do you think that his weeing is okay? Any reduction in the number of wet nappies?
No, it's been fine actually. So he's been
How is his
passing
bowel
poos.
motion?
Bowel motion's been okay. He's been passing at least 2 to 3 nappies per day, and they're adequately wet. And yes, bowel motion has been fine as well.
Okay, while feeding, does he cries or have you felt any lump in his tummy?
No, no, doctor.
No. And is there these rashes present in the mouth as well? Like
no, doctor.
No. Okay. And is there any is he the only child you're having?
Yes, we're the first-time parents. This is our only child right now.
Yeah.
Yeah.
Does anyone in contact with him who is having the similar rash?
No, doctor. I mean, it's only me and my husband, so my wife, and we seem to be doing okay.
And does he sleep well, or
He's
is
been
this?
sleeping well. Yes, he's been sleeping
Okay,
well.
right.
Yeah.
So may I ask it when the mother was pregnant with Tracy, does she had any kind of infections or complications during the pregnancy?
No, doctor.
And when she delivered, was that any complications, prolonged labor, or any kind of infections with the mother?
No, doctor.
And has he got admitted after the delivery, like any long stay in the hospital?
No, doctor. No.
Okay. Any jaundice?
No
Okay.
jaundice.
And what about his heel prick?
Yeah, they're all fine. Yes.
Okay. And is he having his immunization up to date?
Well, he's only 7-day-old, so he's had the basic
Okay, so the
immunization on
first,
day 1. Yeah,
right.
It's been done.
Okay.
Yeah.
Okay. And any recent traveling if you have done?
No, doctor. We've just been at home because obviously of the little baby. We've not been out much traveling.
Did you apply
He does get
anything?
visits. Yeah, he does get like a lot of family relatives. His grandmother and grandfather come and visit him, obviously. So he's getting a lot of visitors coming in. Yeah,
Right.
because it's the first child of the family, first baby of the family. That everybody wants to come and meet him.
And have you applied anything which you think that maybe getting trouble could be the cause of this rash, like any creams or any?
No, we've not been applying any cream. We've just been using a little bit of olive oil from time to time, but that's about it really.
And do you or your husband having any history of eczema or asthma?
No, doctor, no.
Right. So anybody smokes at home?
No, ma'am.
Right. Okay, so according to the history, Rizwan, which you have given to me, it seems that the temperature is not high, so I'm thinking about it something viral. But the rash appears a bit pus inside it.
Yeah, doctor. That's what the GP was concerned about. That he said it looks like it's infected.
Yeah. So and as the child Tracy is eating well and he's not dehydrated as well, no temperature is there, but still the rashes are getting worse, so I'm a little bit concerned about it.
Yep.
So
what do you think
I
is
might
going on,
take
doctor?
the swab. of it
Yeah.
and send it for the investigation for
Perfect.
culture and sensitivity, that what could be the bug or the germ which is causing that. Otherwise, I would like you to just hydrate the baby and
Okay. So
I'm not
what is going
sure.
on? What do you think is going on? Does it need any antibiotics, you think, or?
I don't think so, because the temperature is not high. Until 3 days, we cannot advise any antibiotic.
Okay.
We can wait for the
Swabs
swab,
to come
and
back.
when the results will come, we might check again the temperature, and if it's going high, then we could start NEO. But at the moment, I don't think so.
Okay. All right. We'll stop there. Thank you, Dr. Amber. That was good. How do you feel?
It's okay.
It's not an easy case, I must say. It looks very innocent and cute, but it's not easy, right?
Yeah.
Yeah. So look, I mean, this is a condition called, what do you think is the condition? Anybody? Yeah, go for it. You can't go wrong.
So it looks like the mother was in contact with some person during pregnancy and the child has developed maybe a chickenpox.
Okay, so that could be one differential. Could it be, a varicella infection?
Yep,
Okay.
varicella.
What could be yeah. But for that, they're usually eruptions are very crusty. It's somewhat different from that, but that's a good differential. Don't worry about that. What else? What could be the other differential or diagnosis? It looks very golden. When you see the lesions like that, golden with redness, what is the word which comes to your mind? Often starting with I.
Impetigo?
Yeah, impetigo. So it is actually one of the condition called bullous impetigo. So when I was seeing this patient in emergency department, I knew that the child looks well, feeds well, and does everything which is well. But then again, this redness is getting worse. And there was actually a large one on the groin as well, which was actually quite big and had opened up and was weeping. So that was a concern, even though, and then I looked it up and read around it, and these can often present in a way where the child is well, and then suddenly becomes febrile, because they're getting plenty of auto antibodies from mother's breast milk. So they're getting like antibiotic treatment as we go along. But then again, these things can overwhelm. So good effort, Dr. Amber. One thing I'd like to say, don't use the word anxious for parents. Now, I can use the word anxious. Or think about use the word concerned. If you say anxious, I want you to calm down, then these are often treading on to, or you think that I'm having an anxiety attack, which she might well be having an anxiety attack. But use the word, look, I can genuinely feel that you're concerned about the well-being of your child. Let's work it together and talk about it. See what's the best way solution. I often start off with the framework that, look, Rizwan, you've come in with your baby Jimmy and you're concerned about this rash on the skin. Can you tell me a little bit more about it and what we'll do from there? After taking some information, I'll examine and perhaps do some tests and get some pediatric information. So the framework. So even if you're not getting to the end point of management and differentials, at least you've given the framework. This is what's going to happen in the next 6 to 7 minutes. All right. And then you go start. You've asked good question in terms of my red flags. The feeding, obviously, the birth history is very important. Could this child have contracted something through the birth canal during the process of birth? Could there be a localized infection in the vaginal tract, which the child caused, obviously being exposed to that skin? Could this infection be subtle, causing issues with the feeding problem? Because that is often the first thing which upsets the children. Feeding issues, loss of weight, diarrhea, not making wet nappies. So that was good. Other thing, very good. You checked about family history of eczema and asthma. Is there a family history of atopy? Is there a family history of eczema, which obviously, even though he's quite young, but then does make it very strong point that this could be something which is genetic tendency and somehow it's represented a bit early. The third point which I had in my mind was, which I marked as a critical care, to take a swab. Absolutely must. You must take a swab from these lesions. When I'm telling you they're weeping, they're large, they're golden crusty, because you want them to be on a specific antibiotic. Okay, now you can start them on empiric treatment, but then obviously You want them to be on specific antibiotic. Now, I don't know why you were checking the vitals again when I've given you vitals. As I said, don't repeat yourself. You've already got that information. You need to act on that information. Don't waste time there. Yes, so in terms of, you've taken the birth history, you've taken the delivery information, well, no fever, feeding, breast milk, good feeds, normal stools and urine. Then coming back to the differential. So even though your commentary is quite adequate, if you say, for instance, you've got no clue about what's going on, the salvageable way of dealing with that, or safe way to deal with that, is that, look, I'll get a pediatric doctor to come and have a look at little Jimmy, because this is a slightly concerning aspect that this rash is getting worse. It is getting red, it is spreading. And I would like to have an expertise whether it would need a closer eye observation, whether it will need specific treatment with antibiotics or not. And then obviously it needs to be followed up. So in that way, you've done what is called a shared decision-making process.
Yeah,
right?
but he's in the GP setting, yeah?
Brought to the GP. Oh, yes. That's right. So you can say in a GP setting that I would like you to send you to the hospital so that he can be reviewed by the pediatric doctors and they can have a look at these. So exactly the same thing. And you can make a shared decision-making process. If you've got no clue about what's going on, involve the senior. In fact, I'll tell you the natural history of this patient. When this patient went to the GP this morning, the GP did not have any idea. That's what the mother told me. The GP had no clue what's wrong with the patient. He called in the senior GP at the practice. And the senior GP had written bullous impetigo on the referral letter and then send it for a pediatric review. So this is a tip of practical life. It is always okay not to know about something, but it's not okay to have that senior review. So obviously coming to me in emergency department, my job was to make that transition between the GP and the pediatric. And, when I had a chat to pediatrics, she was quite right. She was quite a senior advanced trainee from Children's Hospital Westmead, who's rotating in Liverpool Hospital. And she said, look, I've seen these infections. The child actually look well in the first week, but by about 10 days, they get systemic signs of illness with, high fevers. They stop feeding. In fact, my decision after reviewing this child would be based on the fact that whether he needs an IV treatment now versus an oral treatment. There's no doubt in my mind he needs treatment, but that's the decision which I would be making. The other thing about the management aspect, think about the general aspects. One information that I've given you, that there's a lot of visitors coming in to visit him because this is a first baby child. Hand hygiene is very important, which is often not practiced. This was a child in which dad was islander. I'm not being judgmental, but they've got like big families, and so there could be a transfer of like staph is a common colonization bug on all our skin. Impetigo is mostly staph, or in some instances strep. So this is a common transfer infection from a dirty hand hygiene. So prevention is better than cure. Talk about, in the meantime, we need to focus on keeping the skin clean, making sure that he's not getting frequently touched by strangers. And that could cause further transfer infection, especially when he's got open skin wounds. They can spread and get infected. So just to make a point of that. So this is bullous impetigo. The other, sorry, go on, Amber. I felt that
so Dr. Rizwan, in this scenario and the history which I have taken, I could not get anything which make me like he's a serious patient, or should I admit it or refer it? So what will be the, first baseline thing?
Yeah. So as I said, that when you have got little information in terms of the severity of the illness, but obviously the parents are concerned or anxious being first time, you need to escalate it to a different person, a senior, a pediatrician, a person who can follow them up, even though you might be 100% okay of not starting the antibiotic right now. But you need to pass it on to someone who can actually keep them under a close follow-up. And we do that all the time. The most common scenario that may come in AMC, the child is actually not feeding well, has lost a bit of weight, but does not look unwell. And you need to, what do? You send them to a peds clinic follow-up. So just disperse and escalate. All right. The other differentials, I was reading up that scenario when I came back home. It could, obviously, we've talked about bullous impetigo. One thing, a red flag to exclude with any rash would be obviously asking about the fevers and all that. Could it be, meningococcal like? Doesn't look typical of that. So the other differential could be varicella zoster. There is another thing called neonatal pustular psoriasis, which I was looking up, looks very similar. So there are a few differentials which could come up to. Now, why is these rashes important? Because of the spread. It could cause staphylococcal scalded skin syndrome, if you know what I mean. You may remember this term from your AMC part 1. It's that systemic unwellness which the pediatric registrar was talking about, in which skin becomes very tendery and papery, and there's large areas of desquamation. Okay. And and that's about it really. So quick tips whenever you're talking to the parents, like your approach, very good, very gentle. Make sure that you use the word concerned. Let's work together, phase out the best managed plan. If you've got no clue or idea about what's going on, always escalate with any information. If you're in a GP practice, escalate to the hospital review for that particular specialty. If you're in a hospital, get your senior involved or involve that specialty. Give it a plan in your understanding from the management point of view in terms of basic management, hand hygiene, keeping the skin clean. If it's weeping, obviously may need some dressings and things like that. So this is neonatal pustular psoriasis. Look how similar it looks like, isn't it? These same whitish specks, but it is far less serious than what we have seen in the previous scenario. All right. And the other infection or differentials would be herpes. But then these patients are quite sick, right? The patients with herpes because these are painful rashes. Herpes is always, by definition, painful. And they get contracted herpes while passing through the birth canal. All right. Okay. I'll get Dr. Farwa to tap in with our cases then.
Yes, sir. Thank you, sir.
Can you share your screen, Dr. Farwa? I think.
Yes, I will.
All right. I'll stop my sharing.
Yeah.
Okay, good.
Okay. So hello, everyone. Today, I'm having 3 scenarios for all of you. If I just need to ask a bit about the role playing of these scenarios from Dr. Rizwan. If anyone is supposed to come and role play, or am I supposed to explain myself?
Look, I think I would imagine that people should be very keen or super keen to give it a try. So please role play. And Dr. Farwa is an excellent teacher. And when you role play, these scenarios will be prepared. So please raise up your hand. Doesn't matter if you make a mistake, you learn something and we'll take it from there. So don't feel shy and obviously use this opportunity. So who will do the first scenario for Dr. Farwa? Who's that? Chris is.
Sorry.
Is it Christina?
Yeah, I can do that. Yes.
Okay, perfect, Christina. That's all right.
Yeah.
Perfect.
Thank you so much.
Yeah, I might be having a little bit background noise.
That's
no
okay,
problem.
Dr. Christina. Dr. Christina is an emergency registrar, works in Liverpool Hospital. We were working yesterday, last night together, finished midnight. So she might be a little bit tired, but that's okay.
Yeah. So you are a GP at local GP clinic. A 34-year-old woman comes to you for her routine well check.
Yeah.
You did the appointment and the health checkup with the patient.
Yeah.
When she's about to leave, she asks you for a repeat temazepam prescription. In the past, she has always asked for prescriptions in consultation for other complaints. Take psychosocial history regarding insomnia and explain to the patient the most likely cause of insomnia.
Yeah. Okay. So, Dr. Christine, I will be putting on the timer.
Okay.
Probably for 8 minutes. Just to make sure that, everything is completely
goes according to the plan, yeah.
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 Okay.
Hi, I'm Christine. I'm one of the doctors.
Yeah.
In the practice, can I confirm your name?
Yes, doctor. My name is Jennifer.
Yes, Jennifer. So I understand you came for the routine checkup.
Yes,
how did it? How did it go? Is it good?
Yeah, it went pretty well, doctor. I'm really happy that I don't have any problems, any active problems today. And yeah, everything's fine. But the only thing I was concerned of is like, doctor, I really need temazepam. Yeah.
Yeah, I understand that you have requested for a temazepam prescription.
Yeah.
So can I know why what exactly why you are on temazepam?
It's just like that. I'm not habitual of taking that, but sometimes I'm having that lack of sleep, which makes difficult for me to concentrate at work. So that's the reason I really need it to be on the safer side. Yeah.
Yes. Look, I just wanted to ask you how long you have been on temazepam. Like how many months have been taking it?
Doctor, it's been a while now, like 5 months maybe.
Okay, sure. Okay. Look, I just wanted to confirm you that whatever we talk here will remain between you and me, and unless it is harmful to you or somebody else. So is it all right if I ask you a few more questions about the temazepam?
Yeah, sure, doctor.
Yeah, sure. So you told me that you started taking it for 5 months duration. So can I know what was the initial event that you got temazepam started for?
Oh, doctor, what am I supposed to tell you? I'm having such a messed up life. I have no one at home to be with. And it's like, it's horrible. For the past 5 months, I'm all alone.
Okay, Farwa. Oh, I'm really sorry to hear that. Yeah, I know you must be going through a very rough time. So is the problems have been settled by now?
No, they aren't. That's why I need more.
Okay. So, Farwa, can I know what was the dose you initially took?
It was like that my mini tablet, and I used to take that for twice a day. Yeah.
Have you noticed that you're being taking a little bit more, like to get the same effect?
Initially, I used to take one, but these days it's like 3.
Okay. So, Farwa, the one more thing I wanted to ask: have you ever tried to stop taking temazepam and try whether you can have a good night's sleep?
I have tried it a couple of times, but I failed it. Like, I'm just not able to sleep. Then my work becomes a mess. It's like it's so bad for me these days.
Okay, Farwa. Yes. So, can I know how is your mood these days, Farwa?
I'm really sad these days.
Yeah. So, Farwa, are you eating well? You're sleeping well?
Oh, I can't sleep without this pill, and I'm eating pretty much than my normal amount of food. Yeah.
Okay. So I'm going to ask you a little bit odd questions. So there are some routine questions. Are you do you hear or things that others don't?
You think I'm crazy?
Farwa, look, these are kind of a routine questions that we ask from anyone. So it's just to confirm for the completeness of sake. So just do you ever thought that you hear or see things that others don't?
No, doctor, not yet.
Okay. And a little bit more about, so you said your eating and drinking and sleeping is all not going well. So can I know, do you ever felt like the life is not worth living?
Yeah, most of the times for the past 5 years. Yeah.
Okay, sure. Okay. Have you ever had any plans of ending your life?
No, doctor, I'm too scared for that. No.
Okay. And so, Farwa, do you think that you need a professional help with regard to your issues going on with sleep and as well as your mental health?
I don't know, doctor. I think this pill makes me feel better, so that will be enough.
Okay. So Farwa, now I'm going to ask you some hypothetical question.
Yeah.
So just think there's a fire inside this room. What are you going to do?
I would run away because I'm scared of dying.
Okay, that's good. So do you know where you are at the moment?
I'm at your GP clinic.
Do you know who I am?
You're my doctor.
Okay. Do you know what time of the day is now?
It's afternoon.
Okay. So Farwa, with whom you live with?
I live alone.
Okay.
Yeah.
So Farwa, you ever are you ever had a partner, or you have?
Yeah, I had a partner 5 months back, but we had a breakup, and since then, I'm having this kind of mental health.
Okay. So are you going out with your friends? Are you having a good social life?
Not these days at all.
Okay. So do you work for Farwa?
Yes, I work.
Can I know what kind of work you do?
Yeah, I work at Gold's.
Okay.
Yeah.
So do you have any stresses at work?
Yeah, a couple of them. My manager is not happy with me because of my messier mood, and I'm more sleepy at work. I'm just not able to concentrate. So yeah.
So Farwa, do you smoke, drink, or take any illicit drugs?
Yes, I do smoke for the past 10 years now. And I used to take alcohol occasionally, but these days I'm just going a bit over that. And no drugs at all, apart from this pill.
Okay. So have you ever been treated for any mental health illnesses in the past?
No, doctor.
Do you have any family history of mental health issues?
No,
Okay.
not that I'm aware of.
Okay. Thank you, Farwa. Thank you for the information you have given me so far. So one more thing I wanted to ask is about your sleep, like at what time you go to sleep and how many hours you sleep.
I tried going to bed like around 10 or 11, but whenever I lie down, I'm just not able to sleep. So that's the reason I always have to take that pill. Yeah.
Okay. So do you find like you're waking up early in the morning and you can't get back to sleep?
Yeah, that's happening with me for the past 5 months. Yeah.
Do you have any nightmares?
No.
Do you use a lot of screen time before sleeping?
Yes, when I'm not sleeping, so I just prefer using my mobile phone scrolling through it.
Yeah. Thank you, Farwa. So let me explain to you the most likely cause of your insomnia.
Yeah.
So that I understand that you have been taking temazepam, which is a sleep medication for 5 months, and now that you have to take more tablets to make you fall asleep. Farwa, this actually for the reason for your insomnia is like causes like multifactorial. There are multiple causes, but it's a good thing that you have whatever the cause initially caused you for not getting to sleep is now has been faded off. So so I have to tell you, like the temazepam actually does not help you to fall asleep in a long run. So what you have to practice more good sleep hygiene. So I'll tell you how you can practice good sleep hygiene. And as well as you need to stop temazepam, which should be done gradually. Like you can't stop it immediately. So I will make a plan for that as well. So like that gradually to reduce your temazepam. And as well as I will introduce you to cognitive behavioral therapy, the counselor therapy, so that they will help you to have some more talk therapy and sort out your whatever the social issues and mental health issues going
but doctor,
on with you.
You are saying, okay, time up. You are saying that you would be decreasing the dose of my pill, but in that case I won't be able to sleep.
Yes. So Farwa, for that question, so I think Oh, the time's up. I think Rizwan, you have to help me with this.
That's okay. I think it is just I think the situation was dually challenging because you had a child distracting you and you were trying to put your level
Yeah.
up. But I'll get Dr. Farwa to just take us through the ins and out of this scenario and expectation, please.
Yeah. Yes, sir. Thank you, sir. Well, first of all, Dr. Christine, you did an amazing job in asking all the right questions. You explored each and every aspect of psychosocial history. You just made sure if the patient is safe to send home or not. That is what required in these kind of scenarios, right? So coming back to the scenario, you are at a GP clinic, right? Now there's a young woman, 34-year-old woman, who has come to you for her well check, but suddenly she comes up with this thing that she needs a temazepam prescription, right? Now you have to take psychosocial history, which would explore that why she was taking benzodiazepine, whether she is dependent on benzodiazepine, right? We need to assess that one, right? And what was the cause she started that on, right? Previously, it was I literally explored that about the question that who started you on that particular drug, but I think that it's not a better option to kind of ask that question. That would be very much lethal for your fellow colleagues. So it's like just stick to like the cause that why the patient started, so that you can kind of address all of those concerns and kind of switch her to a better plan so that she can get rid of the addiction if there is any. Okay, so coming to the history. Okay, sorry. Okay, coming to the history, we have first of all, confidentiality. Confidentiality is very, very important to establish here. Sometimes double confidentiality. Ask the patient just politely that, well, Jennifer, I know that, I'm really happy that you had your well check and everything is fine. But I really was concerned about the fact that why do you want temazepam? Is everything okay? And then establish the confidentiality. Well, Jennifer, you are not supposed to get worried because whatever conversation we would be having would remain confidential between me and you unless and until it is harmful for you or anyone else. Okay. Then start asking questions. For how long you're having this pill, right? How many pills a day? Right? Have you tried increasing the dose by yourself just to make sure that you are assessing the tolerance, right? To get the same effect, right? Then you're supposed to, I won't suggest that ask about, straightforwardly ask about the source of the drug, but you can ask that anything happened after which, as Dr. Christine asked, that after which you started off with this pill, right? Maybe there's some trauma happened, and because of that, any accident happened, and the doctors wanted her to kind of, have a good night's sleep for a short time, but she is so much addicted because of that she has to continue. Maybe something traumatic happened in your life. So that's what we have to explore in that one. Okay. Then comes withdrawal symptoms. We need to explore that has she tried kind of, quitting on those pills? And if she has tried, were the withdrawal symptoms a cause of her of a failure of quitting that particular drug? So we need to explore that when you kind of, whenever you don't take this particular pill, or whenever you miss the pill, do you feel anxious? Do you feel that, any abnormal movements are happening of your body parts? Do you feel any tummy pain, any excessive sweating? Do you feel confused? Okay, so these are the things that we need to explore. Then we need to kind of, we need to check the insight of the patient, whether the patient knows that she is dependent on that particular drug or not. Motivation to quit that particular drug in any dependence, we need to kind of, assess that. Then come to the psychosocial. Although they are asking for psychosocial, but in the end, we need to explore that what are we supposed to do? So we need to kind of, address all of that, right? Psychosocial, follow your head assist, right? What is head assist? Try to explore the mood of the patient. We'll try to explore home situation of the patient. If the patient works or if the patient goes to school. If the patient goes to school, then ask that whether there's any bullying happening, right? At school or at her university, anything. If this patient was like old enough to work, so we need to ask, how's the work environment? Are you satisfied with that? What do you do for work? And is it getting very stressful these days? Okay, we need to explore that. Then comes appetite of the patient. If the patient is eating more or less, both some people eat more while they're depressed. Some people eat less when they're depressed. So we need to kind of assess that. And one of the other reasons of asking about appetite is like, is there any other psychiatric history associated with it, like eating disorders? Those people are more prone to develop other coexisting psychiatric disorders like depression and all of that, right? Assess about the patient's safety. How would you assess the patient's safety? You need to ask that, as Dr. Christine asked, that do you think that life is still worth living? Have you ever tried harming yourself? Do you have any thoughts of harming yourself or any other person, right? Then you can kind of give a heads up to the patient before asking this question, because most of the time they would get insane after hearing this word. Do you see or hear things while which others don't, right? The patient would be like, okay, do you think that I'm insane? Do you think I'm mad? No. We are supposed to calm that patient down, give a heads up that this is something that we ask every other patient, just to make sure that what is wrong with you, so that we are able to help you in a better way, right? Then SADMA. Why SADMA is important here? Because whenever there's one addiction, we need to explore other addictions as well, right? So SADMA is very, very important here. Okay, coming to the past history of psychiatric illnesses, family history of psychiatric illnesses are very important, because obviously there may be some exacerbation of the pre-existing condition, or there may be some coexisting depression. So, we need to explore that. We need to explore that whether the patient was having, how's the general health of the patient, whether the patient had any serious illnesses in the past, any accident, any trauma apart from the breakup that she had, right? All of that. And then what benzos can do. Benzos can cause you, dizziness. Daytime dizziness, somnolence. So we need to rule out whether the patient had a fall because of taking benzos and all of that, whether the patient had experienced any kind of loss of consciousness. So we need to experience that one, right? So this is head assess. We need to explore that. Then comes advise. Ask, assess, and then assist, and then advise, right? So how we are supposed to advise the patient, right? We are supposed to advise the patient about the side effects of the benzos, right? We need to advise the patient that what was the actual purpose of giving that particular patient those benzos, or putting any patient to benzos, right? Obviously, it is there to treat panic attacks, to treat, insomnias, to treat anxiety for a shorter period of time. They are not something to be taken for a long period of time, because one of the greatest side effects of these benzos are addiction. So we need to be aware of that, right? Okay. And then we need to assist the patient. We are assisting the patient to kind of, how she can get over it. Make a plan for safe withdrawal and cessation. Now, what would be the plan? If we are keeping this patient to like on temazepam, we are not kind of helping that patient more. So what are we going to do is, like, we will be switching this patient to from a short acting benzo to a long acting benzo, so that for this much of dose, like for 5 mg of dose of diazepam, she can get the similar effect which she used to achieve with the 30 mg of temazepam. Make sense? So that's the thing. we need to kind of, stick to our plan, that is gradual discontinuation. How we would be doing it, we would be switching this patient to a long-acting benzo so that, the dose is increased, the dose is decreased, sorry. And the other thing is, like, after the patient is satisfied getting the similar effect with that long-acting benzo, we would be gradually decreasing the dose of the existing diazepam that we have prescribed to the patient. But even for diazepam, we are not kind of, giving an open access to diazepam. We would be kind of, giving this patient a controlled amount of diazepam, right? So we have to liaise with the pharmacist just in order to kind of, give a controlled amount of benzos, and just to make sure that the patient has not started abusing herself with diazepam now, right? So we need to explain all the withdrawal effects to the patient, that this is something that you can face during the initial phase. But if you think that, you are not able to kind of, keep up with the anxiety or panic attacks, or, you're having enough of nausea, you're having enough of tummy pains, muscle aches, you're supposed to kind of, get back to me as soon as possible, and we will be helping you out in every possible way to get through this, right? And anything which is, if the patient is not even able to come by herself or something like that, she can always call 000. Okay, so now here, her main problem was insomnia due to depression, isn't it? Now that we know that, we need to, if the management is one of our tasks as well, so we need to kind of, tell her a bit about sleep hygiene as well, that make sure that you're using the bed only for sleeping and sex, not anything else. Make sure that whenever you go to bed, you are taking a hot water bath, and then you go to bed. Try reading a book before going to bed instead of using screen. Put away all the screens before you go to bed. These kind of sleep hygienes, and just to make sure that, the patient is getting enough of support from you. Lifestyle modifications are very, very, very important here. Follow the SNAP mnemonic, which is if the patient is smoking, here the patient was a smoker, we need to address there and then I would be booking another appointment for you, as smoking is injurious to health, so you need to quit that on. And nutrition, N stands for nutrition. You need to kind of switch to a healthy, well-balanced diet. A is for alcohol. If the patient is alcoholic, you need to address it there and then. You need to ask the patient to cut down on alcohol to a safe limit, that is 2 standard drinks per day. Okay. And the other thing is like physical exercise that would really help in kind of keeping up that mood, and getting away from bad thoughts, depression, and everything, right? Psychologist referral is very much essential here, because for talk therapy, because our patient is very much depressed. Family meeting is always essential. As the patient, if any one of the family members live around here in this city or something like that, you can always have a family meeting with them, or any friends that the patient is having, you can have a meeting with them so that they can assist her with getting out of this depression. Once she's out of the depression, she would stop taking medications, right? So that is our goal. We need to treat the whole patient rather than one of his or her chief complaint. Okay, so that's the goal. Social worker if required, and if the patient is not able to cope up with all the withdrawal symptoms that the patient is having, then we can always have an option to kind of refer this patient to a drug rehab.
Yep.
Okay, so
good. So, Dr. Farwa, would you like to bring up the next case? What I'll get you to do is do one more case, because then we've got Dr. Gulna and Dr. Junaid as well. We'll get to do those cases. So I think that's a very important case, and I can see a couple of landmines here in terms of, I like the way that you've put that whole drug transition planning, that you need to transition depending on your motivation. So that is good to check the motivation level. And I like the way that you address that, do you think I'm mad? And I like the way that you completely changed your facial expression when she said, are you hallucinating? Or when Dr. Christina was asking that, do you see things? So that's very important to reassure them that this is a part of journal is screening. And I'd be asking this question to any person who would be presenting with such symptoms. I think you are absolutely right. Psychologist review and drug and alcohol follow-up would be absolutely vital for this kind of patient.
Yes.
Now, the other thing, just correct me if I'm not wrong. What about the medical clearance? Could this be a part of an organic illness? Like, obviously, it looks like
Yes.
from the history point of view, it is mainly benzodiazepine dependence, but could there be TFT exclusion of blood tests or anything like that? Is it worth doing or not really?
So basically, these kind of scenarios, when we talk about a single drug, it's what they are, requiring is like we need to explore, any addiction of the drug. And then if the patient is depressed, that's the thing. The other things we can cover in past history. But if this is a pure scenario for depression, then we are supposed to rule out all the medical illnesses and all of that.
Perfect. Got you.
Yeah.
All right. Who's going to do the next one? We've got plenty of good cases lined up by Dr. Junaid. Dr. Gulna would be next. And let's just do this case quickly. Very important case. I like this case personally because this is a very frequent occurrence, both in AMC and also in real life. So who's going to put up their hands, guys? Just quickly, in the interest of the time. We've got so many Zoom users, Dr. Faryal, Dr. Fanny, Dr. Samaya. Dr. Samaya Ali, would you like to go, please?
Yes, sir, I would like to go, but I am quite new to the practice, so I will try my best.
It's completely fine. Give it a go.
Yeah, good.
Thank you so much. Yeah.
You're working as a junior doctor in a tertiary hospital and you're about to see Tom, a 15 months boy brought to the emergency department by his father due to barking cough. And in the last 30 minutes, his condition seems to be worst with constant noise. History, PFE of Tom, and talk to father about diagnosis and management. Okay.
Yeah. So, Dr. Samaya, I'm not putting any timer. It's just like you need to address it. I have written the diagnosis mistakenly, but it doesn't mean that you have to exclude only that one. You need to make a good list of differentials and exclude everything. Yeah.
Hi, my name is Dr. Samaya, one of the doctor here today in order to take care of you. How can I address you?
You can call me Jennifer, doctor, and you can call me John, doctor, and my son's name is Tom. Yeah.
Hi, John. Nice to meet you.
Nice to meet you too, doctor.
Let me sanitize my hands for you. So, how is Tom? Like, what brought you to the hospital today?
Yes, doctor, we are so worried about our son, Tom. It's like he is having this weird kind of cough for the last 30 minutes. He was completely fine previously, but now he's having this one and we just don't know what to do. I think he is having some kind of, breathing problem. I don't know. That's why we need to rush to the hospital.
Okay, I can understand your concern. It must be difficult when the child is unwell.
Yeah.
So basically, I want to know for how long does it occur? Can you tell me more about his cough?
Yes, doctor. It was like it has just started off for the past 30 minutes during the day. He was all fine. And what else you want to know about the cough?
Does this happens before with Tom as well?
No, it's for the first time.
Okay, so was he exposed to some irritants that is causing the cough, or it appears suddenly?
It appeared suddenly, yeah.
Yeah. So is it associated with fever? Does he feel unwell, not playing or something?
Yeah, he was a bit warm this evening, yeah.
Okay, so why don't you brought him that time when you feel that he was warm and he was not feeling well?
Yeah, this evening. That's the reason we brought him here. Yeah.
Okay. I understand. So tell me, does he exposed to some something or some place or some environment that brought the cough to him?
I don't think so, doctor. What kind of environment you're talking about?
Does he do some things in order to aggravate or what brings and what aggravate the cough?
It was like whenever he cries, it's not about coughing, it doesn't aggravate the cough, but that weird noise which is coming out of her airways, it just gets worse. when he cries.
Oh.
Yeah.
Okay. Can you tell me more about the noise?
Yeah, it's like it started off like 30 minutes back, and whenever he cries or he's upset, it gets worse.
Mhm. How is his diet?
His diet is all fine. Yeah.
And how is doing the daily activities?
There are no issues with that as well. Yeah.
Okay, thank you so much, Tom. I will be back to you after asking the examiner the vitals and everything. Is it okay?
Yeah, sure.
Okay. Hi, examiner. So I have just taken history from the Tom, the father of Jane, or whatever.
Mhm.
I forgot the name. I'm sorry. So how is his vitals?
What do you want to know?
I want to know about the pulse rate, about the respiratory rate, temperature, and blood pressure.
Okay, his heart rate is 110. His 120. His temperature is 38. His respiratory rate is 25, and his SpO2 is normal.
Okay, and how is his temp? Okay, and I want to know about the respiratory examination. I want to know about the palpitation and the auscultation. I really do to go with the palpitation and auscultation of all the 4 zones of the chest.
Okay, so the air entry is equal and normal on both sides, and there are no added sounds.
No added sounds. Thank you so much for that. And I want to know a little more about the. Okay. I think all good for today. So I'm going back to the father and tell him about the diagnosis. Thank you so much, examiner.
Yeah, no problem. Okay.
Oh, hi, Tom. Welcome back. So I just talked to the examiner, and the examiner told me that there are few concerns about the vitals, and he is feverish today. So I think that there is a bug that enters his body, and that is causing the respiratory symptoms. Are you listening to me, Tom?
Yes, doctor. But what kind of bug it is? Like, my son seems to be very sick. He is out of his breath.
Yeah, I can totally understand your concern, but the child are more prone to the bugs, and because they are developing their immunity, so he will be fine soon. We are keeping our eye on his examination and the management. So I assure you, he will be fine soon. So there is a bug, there is a virus that can go in, that is going into his body and causing the respiratory symptoms, and that is why he is causing these symptoms, and he's feeling unwell. But he will be fine soon. I am going to do a few tests, and that is involving the chest X-ray first and the full blood examination in order to rule out what is exactly the condition is. But as far as the history is concerned, as you told me that he's having a noisy breathe, a noisy cough, he's having fever as well from the evening, and he's not playing well, although his appetite is all normal. So I'm thinking that he's suffering from a condition called Croup. So the Croup is basically a respiratory infection, and the children are more prone to various forms of infection because they are developing their immunity with that. Are you with me,
Yes,
Tom?
doctor. Is it a life-threatening condition, doctor?
Oh, no. That is not a life-threatening condition. He will be fine soon. We are managing, and we are arranging a proper management to him. And for this instance, we are doing few tests. So right now I'm giving you a prescription and also giving you a referral to the lab. Are you on a Medicare or a private insurance?
Medicare.
Okay, all good. So I'm giving you a referral to the med lab. So take him to the med lab, do these tests, and came back to me within 2 days. And they will forward the reports to me directly. Is it okay?
Okay. Thank you so much, doctor.
Thank you so much. And come back when there is when you feel like he is quite unwell, come back to the emergency department.
Okay.
And I'm giving you the reading material so that you will be aware of all the conditions, all the problem he's having. Is it okay, Tom?
Okay. Thank you so much,
Thank
Doctor.
you so much. Thank you so much, Tom. Have a good day. Bye.
Thank you. Well, how are you feeling, Dr. Sumaya?
It's my very first role play.
It's okay. You have stepped in. So this means that you are having this motivation of passing this exam in a single go. It doesn't matter. We all have been through that phase. So it's important to step in first. Okay. So Dr. Sumaya, first of all, I would like to ask, like, in your for example, when you were kind of reading the scenario, what was the list of differentials that came in your mind at that time?
Yeah, so basically I was thinking about the respiratory system specifically. So as the child is 17 months, so I exclude this bronchiolitis thing. So I was thinking about croup and pertussis specifically, yes.
Okay. And any other thing that comes in your mind?
So the child, like in the history, it's not written that the child is having fever and anything else like that. So I exclude TB and everything. I just concerned with that group specifically because there are no vitals mentioned here.
Okay. Okay. So, Dr. Sumaya, if I was spending those 2 minutes, like which you will be spending like outside the exam, first of all, try to read your task. Okay. So that if you run out of your time, you're not missing out on your task, right? If you have a face-to-face examination, the question wouldn't be like all the time on your screen. If it is an online exam, it would be, right? So in those 2 minutes, try reading your tasks first and then get back to the scenario, right? What does the scenario say? What are the things that you need to emphasize on? Number one, who are you? You are a junior doctor. Where are you? You are at a tertiary care hospital. Okay, this is something very important. I noticed that, you didn't escalate this case to, your registrar or something like that. So maybe that was a confusion, that whether you were at a GP clinic or a tertiary care hospital. So you are at a tertiary care hospital, right? So if there's any emergency, that can be dealt in a tertiary care hospital. You don't need to refer this patient. This means that. And then who are you dealing with? You are dealing with a 15-month-old boy and who has presented with barking cough for the past 30 minutes with constant noise in his breathing, right? So what does that mean? This means that the boy must be in distress. And first of all, we need to shift this patient to a monitored area just to keep an eye on his vitals, making sure that the patient is in a safe place while we take a history from the parents. Okay. So whenever we are starting off with this kind of history, once, shifting this patient to a monitored area, we will be starting with the chief complaints like cough. Okay. Here, cough and noisy breathing are two complaints which are mentioned, right? So for cough, you can ask, you have a list of differentials. What is the list of differentials? Croup is one of them. Epiglottitis is one of them. Pertussis is one of them. Bronchiolitis is one of them, right? Foreign body inhalation is one of them, right? So these are my top differentials that I need to consider. This means that I need to ask questions in my history which are relevant to these things, right? So cough, you need to ask that since when it is happening, right? It's a young baby. So you are not supposed to ask whether it is productive or non-productive. You are not concerned with that. You need to ask that what is the nature of the cough? Anything which makes it worse or better? Does he cough? Cough and vomit? What does it indicate? It indicates pertussis. The examiner would know that you have ruled out pertussis in your history, making it one of the differentials in your list, right? Then any associations with this cough, like any fever with this cough. If anything comes out to be positive, try to explore that fever history, right? Since when he's feverish, have you checked it with a thermometer? Any chills and rigors associated with it? All of it, right? Any vomiting associated with this cough, right? Any drooling of saliva associated with this cough? Have you left him unsupervised at any time, right? By any chance, do you think that has he kind of kept anything in his mouth, right? So that would exclude foreign body. Drooling of saliva would exclude epiglottitis. The examiner would know that we are using those specific words in our history to exclude our differentials, isn't it? Okay. Then comes after exploring the cuff and everything, we need to kind of, ask some questions which are completely pediatric related. What are those questions? Well, baby questions. Normally, what a baby does, he sleeps, he eats, he poops, he bees. We need to ask these 4 questions, right? We are supposed to ask about if he's eating well. Yes, he was eating well. Has he tried eating anything since for the past 30 minutes? The parent would be like, no. Okay. Has he been sleeping well? The parents would be like, yes, it has just started, since it has just started off, right? So it hasn't affected his sleep. The other thing is like, how would you ask about wee and poo? By any chance, have you noticed any decreased number of wet nappies? What would that indicate? Whether the baby is having any kind of dehydration or not. This is one of the most important things that you need to ask, right? Then comes poop. How would you, you just have to kind of, go through that any problems with his bowels or, like that. Then comes, after the well baby questions, the thing that comes is like, binds mat. What is that? You need to explore birth history. Why? Because one of my differentials is laryngomalacia. We need to explore how was the birth. Was it a normal delivery? Any resuscitation happened after it? Any NICU admissions after that, right? To rule out laryngomalacia, right? Then we are supposed to ask about immunization. Are the immunizations up to date? Why? Because whooping cough is one of our differentials and its vaccine is available. So we need to explore that, right? Then comes social history. Social history is very important because at the age of 3 months, a child can be sent to a daycare, right? You need to explore any sick contacts, right? So just ask that whether the child goes to a daycare or not, right? Any sick children there that you have found. Okay, any pets at home, any carpets at home. It's very important to explore that to rule out any allergies, allergic asthma or something like that, right? Although you can't label the patient as asthmatic before a certain age, but it's like you need to explore that any pets, any carpets, any allergies that the patient has to any specific food or anything, right? Have you traveled anywhere? Because these days we need to explore, we need to rule out COVID pneumonia as well. We need to kind of, explore that. Then past history of any hospital admissions, just to make sure that whether the patient was having any repeated hospital admissions prior to this presentation because of any breathing problems. Okay, so that's what we need to explore. Any surgeries, just a part of the history, family history of asthma or any skin allergies. You need to explore atopy, right? So here, the purpose of PFE would be you have to rule out all of your differentials on the basis of that physical examination. So keep that in your mind while asking all the physical examination findings from the examiner, right? You need to establish a probable diagnosis in Croup. Whether there in Croup, are there any in Croup, are there any specific lung findings? No, you won't be finding anything down below. Why? Because it is an upper respiratory tract infection, isn't it?
Yes.
So we need to kind of, we need to explore that. But are you supposed to examine the throat in Croup? No, you are not supposed to.
Patient is in pain, yep.
No, because the patient would get upset and, this could lead to a disaster if it is not a Croup, if it is epiglottitis. Right? So that's the reason any barking cough, any stridor, we are not examining the throat. Okay. Yes. So, and the other thing is like, if it is Croup, what is the severity of the disease? Does the patient lies in this green portion or amber portion or red portion? We need to explore whether the patient is conscious, whether the patient is having, any stridor. If the patient is having any stridor, whether it is on activity or at rest. At rest, you would be, that would be alarming even more. Okay. If the patient is having any normal and air entry or not, any added sounds or not, whether the patient is having any intercostal recessions or tracheal duct, right? Just to make sure that what is the severity of the disease. Okay, so this is how we'll do it. In Croup, most of the times it's a low-grade fever, or sometimes it gets high grade as well. Sometimes the patient is having normal temperature, so you're not supposed to get confused with that, right? Then you are supposed to explain the patient, how you are supposed to explain anyone about a particular diagnosis. Follow your 5 C's. What are 5 C's? Condition, cause, commonality, cure, complications, right? That would lead to an ideal explanation of diagnosis, right? So here it was an infection of the voice box and windpipe. It's better to draw it on a paper. Sharpie would be your best friend in your main exam. So just try to draw it like on a paper. If you're in a face-to-face exam, then use whatever is available. But if you're in an online exam, then just use a Sharpie to kind of, draw the patient's lungs as well as the airways. Just say that this is your voice box, and a bug known as parainfluenza virus, whenever anyone gets infection via this bug, this tends to kind of, attacks your voice box in the first place. And then your voice box tends to swell, and that swelling leads to decreased or narrow airways, which can cause stridor that you are having that your son is having right now, right? So that's how you are explain it. Just tell the patient that it is a highly infectious thing. We are not supposed to do any investigations in case of Croup. It is purely a clinical diagnosis, right? Are we supposed to admit this patient? If it is mild, then no. If it is moderate to severe, then yes, we need to give this patient a trial of steroids, right? If it gets better with steroids, we need to observe this patient in the emergency cubicle for good 30 minutes, and then send this patient, after discussing it with your registrar, you can send this patient home, right? If the patient doesn't get better with a single dose of steroid, you can kind of, switch to your next level of management. What is that? That is nebulized adrenaline. Okay. You need to give that. And then how much you need to observe a patient after that? 4 hours after adrenaline. Then if the patient is not having stridor at rest, the patient is calm, the patient is having normal breathing, no intercostal recessions, the patient is not in distress, after discussing this with your pediatric registrar, you can send the patient home. The other thing you are very much concerned of is like dehydration. So how would you address in your management? You need to give oral fluids to the patient, right? If the patient is able to tolerate any. In these kind of cases, in most of the cases, the patient would tolerate oral fluids. So that would be your preferred method, right? So this is the treatment chart that we are supposed to follow while managing Croup cases. Okay. So any questions?
No, excellent. That's very good. And the other thing, which while everybody's thinking of the question, is Croup should not be even examined orally. Like, you're not meant to be doing an ENT examination. Anything which distresses the child could cause a sudden closure of the airway.
Yeah.
Because you never know, could it be underlying epiglottitis, as you were saying, Dr. Farwa? So I think that's a very important point to remember.
Yeah.
Not to distress the child.
Yeah.
Okay. Has anybody got any questions? Dr. Hafiz has got questions. Sorry. Dr. Hafiz, you can go and ask a question, please.
I just want to, I'm not sure about if we can highlight about the foreign body, like whether the child was around some toys or any choking episodes he has.
Yeah. On physical examination, you would be able to kind of, clarify it.
No, we don't ask in history.
We have to ask in history. Everything which is to be asked in history, you need to kind of, justify it on the basis of your physical examination.
So with this type of scenarios, you do X-ray?
No, if nothing comes on physical examination, why would you go for an X-ray? No.
Okay, if there is a foreign body.
Yeah, if there's a foreign body, there would be decreased airway, air entry on one of the sides, isn't it?
Yep.
Yeah, so that's the reason.
So
the point is, Dr. Hafiz, so the point is, Dr. Hafiz, that if examiner is trying to give you a scenario of the foreign body, the scenario would be constructed in a way around the foreign body. The child was unattended for a while. Now he's got sudden deterioration with respiratory distress. He's got a stridor or choking episode or coughing or drooling, something like that on those lines.
Yeah.
Then
Okay.
obviously layer it up with your assessment in terms of asking key examination. Yes, there were a bunch of Lego pieces lying around. There was something coin in his hand or something I saw. So there would be pointers there. And obviously, as Dr. Farwa was saying, if there are pointers in the history and in the assessment, then you go and do the X-ray. But obviously, if the scenario is more on the lines of infective pathology, like, there's some fever, there's some shortness of breath, there is cough which is barking. So these are the telltale signs which are pointing to you a very certain diagnosis. So we need to stick to that. Otherwise, it'll all get very confusing. Like, could this be croup? Could this be foreign body? Could this be pneumonia, asthma? Or there could be 100 different causes for everything. But I think it's everything based on history, examination, investigation.
Yeah.
Now, we'll move on to Dr. Gulna. I think she's got some case. Dr. Gulna, you can put up your slides if you like.
Yes, I'll share my screen.
Dr. Amber has actually got a question, I guess.
All right, Dr. Amber, please go ahead.
Yeah, I just wanted to make sure that croup and epiglottitis are the two conditions where we are not going to do the ENT examination. Am I
Yes.
right or wrong?
Yes.
Correct.
So other than that scenarios or the case, we can go for ENT examination, right?
Yeah, definitely.
Yeah, sure. Thank you.
So is there any other question anybody wants to ask regarding the previous case?
No, I think in the interest of the time, we'll start Dr. Gulna. I think
Okay.
Case, and
So
then I'll
Dr.
get Dr.
Farwa-
Junaid. Dr. Junaid, if you can be ready after Dr. Gulna's case, then we'll go to. I know you've been waiting for a while, and I'm sorry you've been awake.
No problem. No
So,
problem.
guys, who would like to volunteer for Dr. Gulna's case? We just need one volunteer, please. Please. Anybody who can volunteer?
I'll do it.
Okay. Who's that? Sorry, I. do it?
Sharon.
Okay, excellent. Thank you, Dr. Sharma. Okay.
So what we need to do is that at the end of the day, on exam day, you need to be properly timed. So I'll give you a timer for around 6 minutes for the history, because this tiredness case, you have a lot of time to take the history, and 2 minutes for diagnosis and reasons. I'll give you a PFE card as well, okay?
Okay.
So you can read the question aloud.
Okay. 47-year-old John presents to the GP clinic complaining of tiredness. Task history, PFE, diagnosis with reasons.
Mhm.
Okay. We're going to start.
When you're ready,
Sure.
you can start.
Anytime.
Okay. Hi, John. Dr. Shamisa, I'm one of the doctors here. What brings you in today?
Doctor, actually, I'm very much concerned because I'm feeling a lot tired these days.
I'm so sorry to hear that. That must be very concerning for you. When did this start?
Doctor, it started like a few days ago, maybe a week.
Oh, okay. So do you feel tired the whole day, or just a particular time of the day you feel tired?
I'm feeling tired throughout the day.
Oh, okay. So is it just one part of the body that you feel tired, or the whole body?
Whole body, doctor.
Okay, all right. Okay, I'm so sorry to hear that. So with this tiredness, how has it been affecting like your life and everything?
Yeah, doctor, it's affecting my daily life, and I'm not able to go to work. I'm all the time very feeling tired.
Okay, I'm so sorry. Hey, so I'm going to everything. I want you to know that everything that we discuss between us stays between us, unless maybe there may be harm to yourself or to someone else. Is that all right?
Yeah, sure.
Okay, all right. So when this tiredness started, was there any particular thing that had happened in your life? Like maybe
Not that I remember of, doctor. I'm
okay,
not
all right.
sure. Yeah.
So besides the tiredness, are you sleeping all right?
Yeah.
Okay, you're sleeping all right. And
Yeah.
are you eating well?
Yes.
Okay, all right. Can you tell me about your home situation?
What do you want to know, doctor?
Any financial issues or changes in the family?
No, doctor, I'm working well. Everything is fine.
All right.
No
Okay.
issues. Yeah.
All right. And how is your mood?
Mood is well, doctor.
Okay, all right. Any recent infections like fevers, upper respiratory tract, like colds and stuff like that?
I have fever, doctor. I'm running fever, and I am having a bit of sore throat as well.
Oh, okay, all right. When did this start?
A few days ago, like maybe 4 to 5 days ago.
Okay. So with this fever, are you having chills and rigors as well?
No, not really.
Okay. So this fever, is it coming and going, or it's constant all the time?
Doctor, whenever I take medicine, it goes away.
Oh, all right. What medicine have you been taking?
I'm taking paracetamol.
Oh, okay. All right. So you also mentioned that you've been having a sore throat.
Yeah.
Okay. Did you see a doctor about that?
No, I thought it will go away by itself. I'm just taking some herbal medicines. That's it.
All right. Okay. So are you struggling maybe with eating?
No, eating is fine.
All right.
I don't feel that much hungry, but eating is otherwise it's fine.
Okay. All right. So what about with the sore throat, any headache or maybe having pain on your sinuses?
No.
Okay. Have you noticed some loss of weight, loss of appetite?
No, doctor.
No. All right. Okay. Have you noticed maybe a funny racing of the heart or shortness of breath?
I have the shortness of breath, and sometimes I feel like there's a racing of my heart, but it happened just a few times. Yeah.
Okay. So with the racing of the heart, does it become very fast or?
No, doc. Yeah, it becomes fast at times, and then it's fine.
How is your diet? Do you eat green leafy vegetables and do you eat meat?
I eat everything, doctor. I try to stick to a very healthy diet plan.
Okay. That's good. I would also want to know about work. How is your work? Any stresses at work?
No, doctor, I told you everything is fine at work.
Oh, okay. Any family history of sorry, not family history, your own personal history of your health that you would like to share with me? Like how's just been your general health?
Generally, I'm well. As I don't know what else do you want to know, doctor? Any specific thing?
Like do you have diseases like maybe diabetes? Have you ever been diagnosed with diabetes, with hypertension? Do you have medications you take for maybe chronic illnesses? Even maybe
No,
okay.
Doctor.
All right, okay. Any joint problems?
No, doctor.
Okay. Have you noticed any skin discoloration?
I haven't noticed, but I have something going on my hands right now. I have some lesions I have noticed.
Oh, okay. When did you notice them?
Doctor, I've started noticing all of this stuff like 1 week or 5 days ago, 5 to 6 days ago.
So these lesions on your hands, where exactly? Can you point on your hand?
Doctor, they're on my joints, along my joints, the fingers.
Well, what color are they?
Doctor, they're like, no, they are painless and they are skin colored.
Oh, okay. Have you noticed maybe stiffness in the joints?
No, doctor, nothing like that.
Okay, all right. Okay, so where besides the color change you saw on the hands, have you seen any other color change on other parts of your body?
Nothing, no, doctor.
Okay, all right. Do you smoke or take alcohol?
I don't smoke, but I do take alcohol occasionally.
Okay, all right. How many do you take? How many like drinks per day?
Doctor, I'm aware of the safe drinking limit, so I make sure that I'm under that.
Oh, okay, all right, okay, that's good. All right. Do you have any family history of maybe joint problems?
No, nothing like that.
All right, okay. So I'd like to talk to my examiner and then get back to you. Is that okay?
Yes, I'll give you the PFE card, okay?
All right, okay.
Yeah, move to the next task.
Okay. Wait, just a minute. All right. Okay. So, okay, I forgot the name of the patient. So, from the history and physical, what, Jade?
John.
Okay, so John, from history and physical examination, it's likely that the sore throat that you got a couple of weeks ago, which you have been, and the fever, which you say you've been taking the medication for, did cause like did cause an immune reaction in your body. Well, you know, the body produces some antibodies to fight against infection. But sorry, I need to repeat this, right? So, John, from history and physical examination, it's most likely that you might be having what we call infective endocarditis. Do you know what that is?
No, doctor, what is that?
Okay, so this is like an infection of the heart valve, the heart valves. This is most likely caused by that sore throat that you had, and it wasn't treated. So then the bug also ended up affecting some of the valves of your heart. So which is then causing you to feel very tired and the funny racing of the heart and yeah. Can I see my task, please?
Yeah, DDs.
Oh, okay. Yeah. So that's what's most likely causing you the symptoms you're having. Also, even the joint deposits you have been seeing on your hands. The good thing is we've managed to catch it, so we can be able to treat you. Here we'll be able to be given some antibiotics so that it can be treated. It usually follows a respiratory infection, or it can also follow a skin infection. And in your case, it's the respiratory infection. So do you have any other concerns?
No, doctor, thank you.
All right, time's up.
Time is over. Yeah. So thank you so much, doctor. You did really well. We'll be just talking about it in a minute. So this is the tiredness. You will get it in every other exam, the tiredness. The patient will be either presenting to you with the tiredness or patient will be unwell. So you need to be like really good with this case because it's a very common case in AMC. Since you had a very good approach, you asked me about how I was doing and everything. You did appreciate the patient that he has taken some time and come to the GP clinic. So we have to ask about the tiredness. That is the presenting complaint. You asked it well. Since when are you feeling tired? Did it happen all of a sudden? Anything making it better or worse? Is it on and off or is it continuous? Do you think like it's the tiredness is happening throughout the day or towards the end of the day? And is this happening for the first time with you? Now we have these two types of questions in AMC. One is related to the obstructive sleep apnea, and other is the all the other causes. So you have to ask me if there is this lack of energy or lack of sleep. We had two cases. In fact, it was a night shift worker who had some problems with his sleep. He was not getting enough sleep. So he usually tells you that I'm having lack of sleep. So that's how you get the idea. That it is because of the lack of sleep, but still you don't have to be, you have to consider all the DDs if the patient gives you any of the positive findings or anything like that. So the differentials, there are different mnemonics for that. I really love the mnemonic hemiphadox, so I always go according to that. So hemi is a H for hemochromatosis, hepatitis, and heart failure. So you have to ask me all of the questions related to that. We'll go through this in a minute. E for the endocrine disorders, like it could be thyroid or it could be diabetes mellitus. Then in diabetes, you also get the cases of DKA. M is for the malignancy. I is for different type of infections, like the case which we had, it was infective endocarditis. It could be HIV, EBV, or travel-related like dengue, malaria, Ross River, etc. It could be because of a chronic fatigue syndrome. After that, you have the A, which could be due to pneumonia or anemia or atypical pneumonia. D, that could be because of depression or drugs. In the drugs, you can even ask me if any drugs you have stopped taking them, what type of drugs are you taking? Because we have a case of steroids when the patient stops taking them, resulting in adrenal insufficiency. After that, we have obstructive sleep apnea, C for the celiac disease. And if the case is females, please always ask her about the periods, pregnancy, and the menopause. That is really, really important. I hope that's clear so far, the differentials. So how we are going to rule out these differentials. So first of all, the hemochromatosis, that's a case in our handbook as well. So you have to ask me simply any tanning of the skin. You can ask like two questions, any tanning or yellowish discoloration of the skin. In this way, you will be able to find out if the patient is having hemochromatosis or any hepatitis or not. If the skin changes are positive, you can ask if there is any change in color of pee or poo or not to look for any obstructive jaundice symptoms. Then for the heart failure, that makes a third of the H, that is the chest pain, any funny racing of the heart, or any past history of any heart-related problems. So this covers our H, the H, 3 of them. Then coming towards the thyroid, the endocrine problem. So thyroid is a very important case. We do get it in tiredness, the hypothyroidism. So you have to ask me about the recent change in weather preference. Now, sometimes people ask any weather preference you have. This is the recent change, because if you have a weather preference from the very start, it won't be counted as thyroid problem. Then ask me about any constipation or diarrhea. After that, you can ask me about a diabetes mellitus. First question is, you can ask me about if I am having any condition called diabetes mellitus or increased sugar levels or not. If the patient says yes, then it's fine. Otherwise, ask if I'm feeling excessively hungry, excessively thirsty, increased need to use the loo, and the family history of diabetes mellitus. For the DKA, if the patient gives you a positive history, then it's fine. We have the case of the child where the patient presents to us with the tiredness, and usually he's working on a farm and he tells you that I'm not able to work help with my parents. In that case, he will be giving you some tummy pain, recent infection as well. So you have to rule out all the causes or all the triggers that could be responsible for causing the DKA as well, diabetic ketoacidosis. In case the patient tells you that I am having a certain type of illness, then you have to ask, at what time were you diagnosed with this condition? What were your symptoms at that time? Are you having any symptoms right now or not? What medications were given to you at that time? Are you taking those medications as been prescribed to you by the doctor? Any increase or decrease in dose of medication? Any extra medication that you have added? And if you are having any regular follow-up with the specialist or the doctor, if you're taking medicine, any side effect of medication that you are having. So these are the questions that you need to ask from every patient who presents to you with any past medical history of any condition on any medication.
Oh, I'll hold it.
Mm-hmm.
All right, good, excellent. Any
Okay.
questions? No problem. Okay, thank you. Thank you very much.
Yeah. So
I think
for the
management, yes, go on for.
No, you don't want me to tell all the hemiphadecs?
No, go for it, please. Sorry.
Okay. So for the malignancy, the important is the loss of weight, loss of appetite, lumps and bumps. These are the simplest question you can ask related to any type of malignancy happening. Then comes the infective endocarditis, which was the case right now. What really happens is that the patient presents to you with the fever, a sore throat and shortness of breath. Now, if you check the feedbacks are very helpful. Usually most of the people do recommend that it's your own choice if you go according to the feedbacks or not. But I personally, I like to read the feedbacks a lot, because in that case, you explore, you can read a lot of stuff which you can get in real exam, because the stem that you read is a lot different as compared to how it's actually in the exam. So you have to ask me about the fever, the sore throat, and the shortness of breath, any infection in the childhood for which you took antibiotic for extended or a prolonged period of time or not, any recent history of any dental procedure, because in AMC exams, we usually get the positive root canal, positive any type of dental extraction has been done or not, any lesions of the hand. It's just, they will hardly ever give you these things. It will be usually in the PFE, but it's better to ask if you think like this is the diagnosis. Apart from that infection, you have to ask me about the travel history, contact history. That is also very important. Ask me about the night sweats for the TB. Now, recently, we're getting the HIV case, and that's really, really important as well. So you have to ask me if we are, after giving confidentiality, if I'm sexually active in a stable relationship. If the patient says that, no, I'm not in a stable relationship, I have a history of multiple sexual partners, then we have to explore more regarding that. How many sexual partners in the last 6 months? Have you or your partner ever been diagnosed with any sexually transmitted infection? Do you always practice safe sex? Or what is your sexual preferences? It is male, females, or both? What route do you prefer? It is vaginal, oral, or anal? Also, last sexual activity, any history of condom rupture. Also ask about the rash and the flu-like illness, because in HIV, they will always give you a rash and a flu-like symptoms. Then come towards the celiac, the other ones, anemia. So anemia, you will be asking me about the diet, any bleeding, any medication that I have been taking, any change in color of the stool, any shortness of breath, or any funny racing of the heart or not. Atypical pneumonia, the patient usually presents to you with the history of travel. And then you also ask me about the fever, the cough, and the travel history. That is very important. The drugs, I have to talk about that already. The steroids, the withdrawal of steroids can result in adrenal insufficiency. So that is very important to ask. Depression, please, even if you ask me about my mood, always tell me that I'm going to ask you personal question to remain confidential between us. There's no harm in giving confidentiality. You have a lot of time for taking this history. How is your mood and anhedonia are the two questions. Obstructive sleep apnea, any snoring at night, any daytime sleepiness. Then celiac is very important. You have to ask me about the personal or family history of special diet and stool that sticks to the pan, or is it hard to flush? In females, it is very, very important. Please ask me about every time about the LMP, if sexually active or not, if using any contraception or not. There's no harm in asking 5 Ps from any female if you have time, because you always, plus another thing is that usually we get a lot of time in taking history. So also make up your mind, what are you going to ask from that patient? Because it gets really awkward if you're saying it, let me go through that again. So just ask about the occupation, how's life going on, any other complaints you are having. If there's a female, ask about the 5P. If she's more than 50, start about the cancer screening, 2 or 3 questions. There's no harm in asking if you have a lot of time, okay? So after that, we need to have a good closure by doing a SADMA. We need to ask about the past medical, past surgical, and the family history. And this is how we take the tiredness history. So now the patient presents to you this one, the one in the case. So she presents to you with the tiredness, and she's having this persistent whole body tiredness. She's also having this, a fever and low duration. A fever was there. Always ask, for example, if the fever is positive, since when are you running this fever? Is it on and off or continuous? Any rigor, chills, or night sweats as well? Apart from that, have you taken any medication? Did the medication resolve the symptoms or not? And secondly, important thing is that have you recorded a temperature or not? Okay, have you sought any medical help for that or not? So after that, I have given you history of shortness of breath. I have given you history of sore throat as well. They can give you a loss of appetite, some body aches as well, and they will always give you childhood history positive of certain type of infection for which they took antibiotic, but they stopped taking it. The compliance wasn't good for the infective endocarditis. Now, other than that, everything is normal. They can have some racing of the heart at times. Other than that, the history of dental procedure is always positive here. If you are in the online exam, they will give you a PFE card. Don't get confused if they give you any type of murmur and you start thinking about, okay, this is the type of murmur, so what is the cause for that? It is aortic regurg, it is mitral stenosis. You don't have to go towards that. You just have to see if there is a murmur present, there's a heart condition present resulting in tiredness. So what could be the possibilities in that case, okay? Now I've given you the splinter hemorrhages, osteo-node, JNV lesion. They can also give you fundoscopy findings, giving you rod spots as well. They can also give you palatal petechia as well. So yes, there could be a lot of findings there, because usually in AMC exam, you have a lot of PFE findings over there. So yes, this is very important to read your task at first as well, because if you manage this patient, it would be good for the patient, but it will not give you any marks, okay? Because the task is to tell me the diagnosis with reasons or diagnosis with the causes. So this means diagnosis and the DDs. Make sure if you have a marker and a pen with you, you practice it with your study partners. If you are going for an online exam, a lot of time how to show it on the camera. So in the exam, you're not struggling, okay, here, I have to put here or there. So do it with that. Use a Sharpie or a thick marker as well. That's very good for that. Apart from that, you can tell me just one line explanation. Do you know this? Most likely you're having a condition called infective endocarditis. The patient never knows what this condition is. So let me explain what that is. Instead of asking, do you know what that is? So the patient will say, no, what is that? So just say, okay, let me explain what this is. Let me draw you a picture. So, when you draw a picture, the patient really gets happy. Because if you consider yourself to a patient, we'll really like the doctor to tell us everything in detail in layman terms. And the picture is the best way to do that. So in our heart, we have 4 chambers. Upper 2 are called atria, lower 2 are called ventricles, and they're separated by a door-like structure, which we call the valves. So what really happened is that you have some problem going on in the valves, and it is resulting in causing this abnormal heart sound, which we call a murmur. Okay. So it is because of certain type of bugs, childhood infection, which has not been treated properly. And once now you have had this dental procedure done, these bugs has transferred back to your blood, transferred by your bloodstream to your heart valves, and it is causing these symptoms in you. Do you understand so far? He will say yes or no. If he doesn't understand, try telling the patient in more simpler words, but patient will understand. Now the task is to tell the DDs. Since we have done a lot of DDs, so what you can do is that you can, cluster these DDs. You don't have to explain to me each and every DD in detail. You can, if you don't have time, if you have time, you can do it. Like you're most welcome to do so. If you don't have time, the best thing is that, okay, this could be because of a condition that we call hemochromatosis or hepatitis. But since you don't have the yellowish discoloration or tanning and other symptoms, so we have ruled out that cause. It could be because of any type of diabetes mellitus or thyroid-related hypothyroidism, but that is unlikely in you. If you don't have time, just saying unlikely in you will even pass you. And please, guys, don't stick to 3 to 4 DDs. Always as much DDs as possible. According to me, I think it should be 6 to 7 DDs, because telling as much DDs is it will always give you good marks. And apart from that, even if the task is not to tell the DDs, just the diagnosis and the management, please make sure you tell 2 or 3 DDs in that task as well. Even if that was the management, you just tell me that infective endocarditis, I was thinking about other condition that could have resulted in this fever and sore throat. Just tell me 3 to 4 DDs as well, and then move to the task of telling me the management. Is there any question? Okay.
Any questions from Dr. Gulna?
Yes, Dr. Somaya, we should ask confidentiality before sexual. Yes, always, and always before the mood as well.
Perfect. I like the way that you've clustered the differential diagnosis and then working up each of the differential diagnoses as you go along. I think it just saves time, and also it makes you come across as very organized in your thought process, and obviously it's all about organization. Thank you very much for that, Dr. Gulna. Now Dr. Junaid is going to discuss cases for me. I'm sorry it's been taken a while, but Zainab is there with us. Zainab, sorry. As Dr. Junaid is getting ready with his slides, Dr. Zainab, so we are doing this session for the AMC candidates for 2. I just would like to ask you some questions in terms of how was your AMC experience like? I know you're at work.
Yes, sir.
What would you like to share with us in terms of your experience and your
Okay.
learnings from that process?
Yes. So with regards to AMC examination, first of all, let me tell you, I'm Dr. Zainab Syed, and I'm working in Royal Darwin Hospital. It's been
and
just
how's
3-4
the weather
weeks.
out there? I'm in
Sir,
Darwin
it's very
next
hot
week.
here. It is very hot here.
Okay.
Yeah. And I am actually getting to see the indigenous population that we are always talking about in AMC examination as well. Okay, now quickly about the exam process. So let me tell you, it is a big, as in it's just like it's just like a horror movie, but let me tell you, it is nothing. And it was an easy journey for me. But why? Because persistence is the key. And obviously it's not about just hard work, but some smart work. So if you have to pick and choose your battles accordingly. So if we are opting for the online examination / physical examination, please modify your preparation accordingly. Do not try to board the 2 ships together. So I took the online examination, and I was among those students who were unbooked, and I just got almost 6 weeks time before I knew that my exam was scheduled on July 6th.
Wow.
Okay, but still I was able to do that, because the catch is I did some smart work. So we had scheduled our timings for, I should not use the word recalls, but it actually helps. And obviously there are some crisp words that they want to listen from you, and then you are there. And the only thing that just saved me was, let's just say, is the approach to the patient. So no matter how dumb you are, or you are more than welcome to do 1,000 complications, but nothing should come to the patient as a surprise. So always wear a big smile on your face. Don't let them know that what's going with you, and that's it. And for every case, obviously, once you go through the syllabus and everything, there is no syllabus. Once you go through the materials per se, so you will get some idea. Okay, if for instance, if it is OBG case, then okay, it's then I'll do some brainstorming and see, okay, if it's gynae or if it is OB. If it is gynae, I will be quickly doing the 5 Ps, and I just remember the 6th, and the 6th thing is the family history or any same conditions. But okay, if it is OBS now, then 5 Ps, I need to shrink them, but for OBS, then I will again split it, whether it is the first 20 weeks of pregnancy, whether those are next 20 weeks of pregnancy. And then this is going to guide your way through, and the role players, they are there to help you. So they do make sure that, doctor, is there anything else that you want me to know? So they will make sure that we complete all our tasks. And besides that, for physical examination, if you go for the online, it's a better option in my understanding. Why? Because you do not need to work a lot for physical examination, especially for people like me. So if you have not practiced back home, so if I went to my GP once and I asked her, I need to learn how to assemble the ophthalmoscope, I actually got tremors because I did not know how to do that. But in the online examination, nothing to tell him, just tell it's an instrument. I'll look at the back of your eye, done and dusted, and that's it. So just be well versed with the diagnosis, come up with a good list, and please explain everything to the patient. And that's it. And and let me tell you, if there is a new case, don't get scared. It is pilot.
Yes, there you go. So simple, nice and easy, punchy. Thank you very much.
Yeah. Okay, that's it. Okay.
No, that's okay. That's good. Now, Dr. Zainab, can you tell us, where did you graduate from?
Yes, sir. I am a graduate from Fatma Jana Medical Institute. But let me tell you, I am an IMG. Period.
Yes. No, everybody who's doing an IMC exam has got to be an IMG.
Yeah, so we are in the IMG. We are in the IMG board together.
All of us, yes. So that's good to get your insights, and it's important, obviously, keeping organized. Look, I don't mind between the online and the face-to-face, because I've done all my exam face-to-face. I think it gives you an added advantage, because the things that you're trying to show in an online two-dimensional format, you can be a bit more in front. But then again, I'm kind of an old fashioned from that point
it
of view.
was my own bias in it. Everybody's free to choose what they want.
Yes. All right, Junaid is looking so bored because he
no, not at all.
Junaid,
can I log off now? I have to go back to work. Okay, all good. Thank you, everyone. Thanks, Dr. Rizwan.
Bye. All right, Junaid, let's do it. You've got the option to share your screen.
Yes.
Perfect. Let's go.
Can you see my screen?
I can. Yes.
Right. Okay, so I've got the first case here.
And who will be the our volunteer for this one? We just need one more volunteer, please. Come on, put your hands up. Be brave. There's so many blank cameras I'm seeing here. There's you, Dr. Mifrad. Would you like to try? Dr. Anam, would you like to give it a go? Anybody? Just give it a go. Trust me, we're not going to do many cases.
I just remember my time.
Dr. Amber wants to go again. Yeah. Okay. Go for it, Dr. Amber, please.
Yeah, sure. So the case is a 43-year-old woman presents with tiredness. Blood tests were advised, which shows the HB is 10.5, MCV is 70, red blood cells are 4.73, and platelets are 200. So white blood cells 5.8, comments microcytic hypochromic anemia, right? So I have to explain the investigations in 2 minutes, and I have to take the history in 5 minutes, and I have to give the diagnosis and differential diagnosis, right? So, okay.
So shall I start your 2 minutes timer?
Yep.
Yeah, sure.
Yeah.
Okay. So should we go, because we have done the tiredness case now?
Yes. Yeah. But there is a catch. Okay. Yeah. Right. Okay. So start, please.
Yeah. Hi. Good morning. I'm Amber, one of the doctors here. How can I address you?
My name is Jennifer.
Jennifer.
Yeah.
Yes, Jennifer. I saw you previously, and we decided to do some blood tests, and your blood tests are here at the moment. And yes, so do you have any specific concerns regarding those tests?
No, actually, I've just come here to know about the blood test results. What are they telling you?
Yeah. So Jennifer, do you have any idea that why we did this test, and what are your expectations at the moment?
Yeah, actually, I was feeling a little bit tired, so you thought that there could be some blood markers which might go down with tiredness and stuff. Yeah.
Yeah. And still the tiredness is same, or is there any difference?
It's the same.
It's the same. Okay. Yeah. So I will be coming back to asking you a few more questions, but before that, let me explain you that the investigation is saying that you are having microcytic hypochromic anemia.
What
So
is that?
let me, yeah. So I will explain you by drawing a diagram here. So it will be for you to understand. So what happens in our blood system? There are three cells: the red blood cells, white blood cells, and the platelets. So the red blood cells actually having the hemoglobin, which means that it's the part which it's the part of the blood which carries oxygen to every tissues of our body, and it is responsible to give some pigmentation. So that is decrease in your blood. That's why you are having some maybe the symptoms.
Move to the next task.
Okay. So now I would like to make sure that what could be the cause behind of this anemia. I would like to ask a few questions. Will it be fine with you,
Sure.
Jennifer?
Yeah, sure, please.
So tell me, for how long you're having this tiredness?
It is happening for the past 2 months.
2 months. And is it every day?
Yeah, it's every day, all day.
Every day. And is there any specific timings you're having it?
No, it's present all day.
All day. And do you feel that more at rest or with exhaustion?
With both.
With both, right?
Yeah.
And right. And can you tell me that any pigmentation or discoloration of the skin if you felt?
No.
No. And any chest pain or shortness of breath if you're having?
No.
No. Have you noticed any lumps and bumps in your body?
No.
Okay. Any changes in your appetite or weight?
Yeah, actually I've been losing some weight, but that's not too much. I think 1.5 kgs this month.
Okay.
Yeah.
And do you think it's voluntarily you are having some diet plans, or it's just happened?
Well, actually I'm feeling tired all the time, so my appetite has gone down too. So I think I'm not eating well these days.
Okay. So right, not eating well. And so how is your bowel motion?
They are okay.
Any changes in your water works?
No.
Do you have any fever or any rash?
No.
Any problems with your joints, pain or swelling?
Yes, actually, I was feeling some pain and aches in my knee joint, and I went to the GP, and they've started me on some medication like painkillers, so they are quite helpful now.
Okay, and it's working, right? And when
Yes.
this joint pain started, can you tell me?
Yes, sorry, about a year ago.
Year ago?
Yeah.
Okay. And have you noticed that your stool color is black?
No.
And do you feel that your skin is having more bruises?
No.
No. And right. So, okay. And I'm going to ask you a little bit personal questions. Will it be fine with you?
Yeah, sure.
Okay. May I ask about your periods? That when was the last?
Yes, so it was about 2 weeks back. My periods are regular.
Okay. Any heavy bleeding or clots?
No.
No. Right. And okay. So, right. And how's your sleep these days?
My sleep is good.
Any changes in your how's your mood these days?
My mood is fine.
Fine. Okay. Are you enjoying the things which you used to?
Yeah.
Okay. Are you taking you said and the medications, painkillers you are taking? May I ask that for how long you are taking this?
For the past 1 year.
1 year. And are you regular with that?
Yeah, I am.
And do you think you are feeling any burning sensation in your tummy?
Yeah, sometimes.
And are you that could be the reason that your appetite is reduced?
I'm not sure about.
And is it related to your eating stuff? Maybe some spicy or oily?
No, I take a very healthy diet.
Okay, right. And What about any past medical conditions if you're having it?
Apart from the arthritis I have, no.
Right. Do you smoke or drink alcohol?
Sometimes, yeah, I do drink.
Any chance of excessive drinking?
No, not at all.
Any illicit drugs if you have ever tried?
No.
Okay, that's good. Thank you, Jennifer, for giving me all this information. I just want to conclude my diagnosis, and I would say at the moment what I assessed from your history is that you're having a chronic condition of joint pain and you're taking the pain medication for that. Most likely it's NSAID medications, which can cause, sometimes the irritation to the food bag, and it can cause ulcer over there, and there could be some microcytic bleeding that can cause your HB level down. Okay, what I'm thinking, but we will do, of course, the investigation, the endoscopy or the colonoscopy to find out and dig it out and make it sure. But other things I'm thinking about could be malignancy, where the bleeding can occur and the weight also reduced and appetite as well. But there's no lumps and bumps in your body, so that might be unlikely. And I would also thinking of dietary effect, as you are not taking much diet, so intake can also could be one of the cause, and sometimes with the decreased absorption of the iron in the tummy,
That's
which
8
comes
minutes,
with
but you
the
can
diarrhea.
go on.
Yeah, which comes with the diarrhea, but you don't have diarrhea, so I can rule out inflammatory bowel disease, which is unlikely. And depression I have ruled out because you are okay with your mood as well. And yeah, there is no urine system and there is no rashes as well, so I can rule out diabetes as well. Yeah, that's it. Thank you. Do you have any questions?
All right. Okay. Thank you so much, Dr. Amber. The case was done really well. It was beyond my expectation, as I think this is your first time or something. So it was done really well. You struggled a little bit to explain the investigations in 2 minutes. And actually, I've given time to all these tasks because, I wanted to create a real exam scenario, because this is what would happen in the AMC exam. So let's go through the case and see what you missed and what you did, right? So first of all the role players are actually given information. So whatever you are asking, they have actually read about the condition and what they have and what they have not, right? So in this case, you actually read the scenario, you build a good rapport with the patient, that I really appreciate that you have come here to know about your blood results. I would be explaining them to you in detail. If you have any questions, please feel free to ask me, right? And then you straight away jump to the investigations because you have 2 minutes. So as your approach was good, that we have, your hemoglobin level has gone down and your red blood cells, white blood cells, and all these things. But first of all, in these scenarios, what you're going to do is, first of all, tell about the negative things. The negative result, like the RBC is normal, the platelet is normal, the WBCs are normal. So it's a good thing that your red blood cells are normal, platelets are normal, WBCs are normal. Try not to worry. I will explain to you what these are. What I found in the results, that your hemoglobin is actually on the lower side. Normally in females, it should be greater than 12 or 13, but yours is 10.5. Also, there is the MCV, which actually stands for the mean corpuscular volume. It should be between 80 to 100, but yours is 70, right? So we have actually 3 lines of blood cells in the blood: RBCs, or the red blood cells, platelets, and WBCs, which are also called the fighter cells. Then you tell about that the red blood cells contains a pigment, we call it the hemoglobin, which is actually carrying oxygen from the lungs to the tissues, right? And the platelets actually helps in clotting, and the WBCs, these are actually the fighter cells. So the hemoglobin is on the lower side. There could be many reasons behind that, for which I need to ask you some questions. This is more than enough for explaining the investigations. Now, you actually build a good rapport with the patient. It builds trust. it improves engagement of the patient, and the patient knows that I'm in safe hands, and this doctor or he's or she is really concerned about my health, right? So as I've already said, that explain the negative investigations first and then come to the positive findings. In between, give plenty of reassurance to the patient that try not to worry, you are in safe hands. We need to dig out more that what is going, there could be many causes. It could be dietary, or if you don't want to tell at that moment, it's okay. But there could be many causes behind this, which I need to ask you, right? Then in this case, always and always I emphasize on one thing, that your history should be well structured. If your history is well structured, you're getting new cases in AMC, you would not panic. Always have a good structure, like first of all, history of presenting illness. The patient has come with tiredness. So my first question would be, since when? Is it getting better or worse? Is it like one part of the body, or is it like your whole body? Is it like some part of the day, or is it present all day? Is there anything which improves it or aggravates it? And is it happening for the first time? I would always ask this question, is it happening for the first time? Because if it has happened before, I need to know, what did you do at that time, right? And when did that happen? Then if you ask about the history of presenting illness, your next would be associated symptoms. The patient has come with tiredness and the blood markers are low. So the first would be, do you have any chest pain or shortness of breath? Do you feel dizzy? Do you have any associated fever? Then after that, I would come to the differentials and 5 Ps. In females, really important, because you have to rule out any menorrhagia that the patient might be having. You need to ask about the pregnancy, because if the pregnancies are not well spaced, it could be because of the previous pregnancy, the patient had any bleeding, or the patient had had not taken any good diet, which is actually causing this anemia. Then we'll come to the differentials later in the next slide. Then I would talk about the past medical surgical history and also the heads. A patient is coming with tiredness, rule out depression always. In AMC, do not jump to conclusions that the patient has come with a low blood markers. I would not go into the heads, or I'm not taking the depression history. Are you with me so far?
Yeah, sure.
Yeah. Then after that, so in the medical history, I talked about arthritis. Then it is better that you ask me what medication you are on, right? Because you assumed while you were telling me the diagnosis, you assumed that I am on NSAIDs. Maybe I am
because
on.
you said painkillers.
Yes, I said painkillers, right?
Yeah.
So it's better that you ask me what kind of painkillers. I would say I am on ibuprofen, right? All your other questions were good, but you did not ask me what medication I am on specifically, right? And then we come to the SADMA part, so the smoking, and you did all that. So this is the history like. Since when, sudden or gradual, whole body, present all day, happening for the first time, and how is it affecting your life? I'm not able to go to my job, right? I'm having financial problems. So I need to dig out that how is it affecting your life, right? Then I would, in the associated symptoms, I would talk about racing of heart, chest pain, shortness of breath, dizziness, fevers. Then in the differentials part, because this case is a little bit different than the previous one. The patient also presented with tiredness in the previous one. But here I have already given you the blood markers. So your history should be more towards bleeding questions or stuff like that. Isn't it?
Yeah.
So so you asked me about black stool. So I assume you were talking about if I have any bleeding in my stool, right? You asked about if I have noticed any color discoloration of my skin. I'm not sure if you were talking about infective endocarditis, or you were talking about like if I bruise easily, right? And any heartburn or water brush, which you asked. Weather preference is important because the patient might be hypothyroid. And specifically, this question should be asked, what does your daily diet consist of? Maybe I'm not taking, iron-rich diet. If I'm having any recent infections. Now, this question is true for thalassemia, that you asked about my ethnicity, if I have like Mediterranean heritage, right? And then the sudden weight loss or lumps or bumps, which actually points towards malignancy. Then after that, we come to the 5 Ps. We are actually following this structure, right? So if you have this structure, you will have everything in line, and you would not panic, and also you would not forget other things. So the 5 Ps in case of females really important. Periods, patient is having heavy periods. You can talk about the partner, like if she's practicing safe sex, in case the patient has positive history of sexually transmitted infection like HIV, which can also present with tiredness, isn't it? Then talk about the pregnancy, gap between pregnancy, complications, pill, pap smear, HPV screening. Because you had 5 minutes for this case, you can ask all these questions. If you have
Dr.
less,
Junaid, we already have like anemia. So should we go only for the periods and LMP, or should we go everything, like all the
well,
Ps?
yes, the thing is actually, if you have 5 or 6 minutes for your history, I would go through all these to just have a complete history. If I am having less time, then I would taper my history. I would ask all those questions which matters, because here the pill does not matter. The pap smear or HPV screening does not matter unless the patient is presenting with weight loss or stuff, right? Yeah.
Okay.
Here actually I'm telling about a good structured history, like how the 5 Ps should be, how the past medical and surgical history should be. You can taper it according to the task and according to the time that you have for that specific task.
Right.
Are you following me?
Yeah.
So Dr. Junaid, there's a question about should we ask about traveling history, or if she is an immigrant, rule out schistosomiasis as well with microcytic anemia?
Yes, exactly. That's a really good question. Like I haven't thought about this question myself, but that's a really good question.
I'm
Yes,
yet to see a
traveling
schistosomiasis cases, but yes.
yes, exactly. Because there are some areas where these cases are,
Prevalent,
the
yes.
incident. Yes. So I'm not sure about Australia, but yes, if she's an immigrant, yes, you can talk about like if any worms infestation or like these things, right?
Yep.
Okay, right. So moving to the next. So in this case, you talk about the past medical and surgical history. Now, in this case, the patient has presented with tiredness. So the psychosocial history, because the previous tutors have talked about the heads, which is really important. And I emphasize the psychosocial history is always important. Do not jump to conclusions in AMC. Like a person would be sitting in front of you, the patient would be lean and thin, and when you ask the patient, how do you perceive your weight, he would say, yeah, I'm very overweight, I'm doing things to reduce my weight. So do not like assume things, always ask the patient. Now here the medication history is positive for NSAIDs, right? So the third task was like, yeah, maybe the patient is having iron deficiency anemia or anemia because of NSAIDs usage. As you are having this task, like you have to just explain the diagnosis and differentials. I would not go into too much detail of this, but I would say like, NSAIDs, when you're taking them, this actually removes or damages the protective layer of the stomach and intestines. And there is actually it causes these small ulcers, which sometimes bleed, but you do not see it apparently in your stool, and that can cause this low hemoglobin level. But also I have other differentials, like it could be some bleeding disorders or heavy menstrual flow. It could be infections. It could be endocrine diseases like hypothyroidism when the thyroid hormone goes low, or it could be because of dietary factors that you are not taking enough diet or or iron-rich diet. Or my last differential would be malignancy. Your diagnosis was anemia due to NSAIDs, and your first differential was malignancy, right? So I would not alarm the patient. Malignancy I would keep on the last of my list, so that I do not alarm the patient, but at the same time I also tell the differentials.
Sure. Yeah.
Do you have any questions regarding this case so far?
No, thank you.
Right.
So I have a question. So this, do we have to take a psychosocial history in this case?
Yeah, so the psychosocial history, the patient has presented with tiredness, right? So I would talk about the heads especially. I would talk about the depression, that how is your mood? Because you would see scenarios coming up. We have actually prepared many scenarios for you and you will be doing them in the sessions. So the patient has come with tiredness. Depression is differential. So you need to ask about depression.
Yeah, now that they have given that there's low microcytic anemia, so I'm asking, in this case also, do we have to ask for psychosocial history?
Well, actually, you do not need to go into too much details, but yes, I would ask about the mood question for sure. That how is your mood these days?
Like a just one question.
Just one question. There is no need of going into the if there is fire in this room and stuff. You just mood questions. How is your mood these days?
Okay.
Yeah.
Okay. I got it. Yeah. Thank you.
Yeah. No problem.
Has anybody got
Right.
any more questions for Dr. Junaid? I think there's some questions. Vegan diet, Dr. Hafiz has said, I think to consider, but I think Dr. Junaid's
Yes.
already touched on, like, you need to ask questions about diet. Okay.
Yeah.
Yep.
Yeah. So I again emphasize on this. History should be very well structured. Yeah.
Perfect.
Okay.
All right. Look, I'll just stop here from the point of view. Thank you, Dr. Junaid. I think we've gone quite a bit over time and we got many cases. In fact, we all prepared. I had 4 cases. Farwa had 3 cases. Junaid had 4 or 5 cases. But obviously it'll be evening. But obviously you can join our sessions to discuss all those cases. Dr. Gulna might have 18 or 100 or maybe 1,000 cases. Who knows? So before I jump in, and I'll just quickly show you, because there's always some questions around the website and the portal for some reason. Can you see the website, Junaid? Can you see the?
Yes.
So I'll start off with the website first. So this is a website in terms of, people often ask me questions that, look, how can we see the upcoming information in terms of these free sessions, in terms of the courses. So if you put in emergencyfocus.net, this is the website. Obviously, I've segregated in terms of CPD courses, AMC courses, and career guidance courses. You can select what you can, and you can jump on. Like if you want to get to know about an AMC courses, I just click on that and it'll open the AMC clinical courses. And there's some free sessions which are already uploaded with a YouTube link in it. And then you can register for the course just pressing on. So we've got 2 courses going on, morning and the evening. And depending on if you want to join them, you can join them. The other thing is about the portal. Once you register for the courses, you'll get an immediate access to the portal. And this is our portal. It is obviously externally hosted through another website, which is a paid platform for me in terms of subscription. But it is where we tend to have all the cases. So all of the course is already preloaded. And if I was to say that you'll get an introduction session in which we'll have these videos, and there's a long sort of introduction session, which will have a complete 3-hour video of some sessions like this, and it'll all have the information that we've already discussed. Now, if you want to go, and this is all the rest of the bits and bobs. So if you start, and when you first log on to the portal, it'll have your performance as like 0%. But as you complete watching, the progress bar will keep on increasing. And once you're 100%, it'll also give you an option to download your certificate of completion with CPD hours. The other thing is that if you want to go and look into pediatrics, we've segregated pediatrics into, say, if I want to look into, I don't know, Down syndrome kind of situation. So there'll be a Down syndrome scenario which has been done. So when I press play, there'll be a role play scenario. There'll be role play scenario happening. Plus there'll be an information to read through this portal down below. Like what are the questions you'd be asking? What is the information in Down syndrome? It'll be all there for you to learn. So you don't have to go back and forth searching for resources. Similarly, if you're looking for something like an allergy, very common scenarios in terms of allergy, there'll be scenario written, and then all the written information that you need to know for an allergy scenario in a pediatric population in terms of, how to give EpiPen day education, anaphylaxis, and so forth. So it is very good. And plus we've got a section. So all of these sections are organized into pediatrics, obs and gynae, then psychiatry, psychogeriatric medicine, physical exam, medicine, surgery, and then dermatology. I've made one section. And then there are flashcard, and then there are live sessions. We've got, actually, I don't believe, we've got 101 live session. So each live session is 3 hours. So you can imagine this 3 hours and 300 hours of course content, which is all organized. So if you're into this long form of listening, you'll see, all these segregated into content. So you can come and have a look at the live session. And then we've got high yield. I know recalls, I should not use the word recalls, but these are all the high yield sessions, which you can click on, and all the high yield sessions that we've done and you have missed out on. So this is a portal for you. If you're registered for course and you cannot somehow attend the live session, which I must say you must attend, but this is like a backup. You can read the scenario, be under an expectation that this is what is going to be tested, and do that scenario. And then obviously to reinforce your learning, you can go through the specifics portal. So that's about it, really. I'll stop here. And thank you very much, Dr. Farwa, Dr. Junaid, and Dr. Gulna, and all the other people who have come and spent time. Sorry, we've gone over time. I did not expect that, but obviously I wanted to cover as much as we can to give you a bit of an idea. And if you've got no questions, Dr. Junaid Ali Khan has got a question. Sorry, yeah, go on, please.
Yeah, it's actually not a question, but I'm telling the candidates that we have actually lots and lots of scenarios prepared for them, and we'll be doing lots and lots of role plays, because role play is the backbone of passing your AMC clinical. That is, let's be very real about that. And we're also touching on most of the recent recalls, because you sometimes do not, find a good approach for it. So I think it would be, it's a good platform for them to, role play and get suggestions and how to pass their exam. Yeah.
Absolutely. It's all about putting yourself, as I said in the beginning, out of your comfort zone. Once you role play, you begin to understand where you're lacking in terms of your specific linguistics, communication skills lack, and knowledge gaps. And they can only, so all of the people who have role played here today, thank you very much. Trust me, you'll remember these scenarios for the rest of your lives. And it'll be like a walk in the park. For if you get this kind of scenario in your real MC, it'll be so much easy for you to do. So this learning is going to be like an amazing learning for you. So without further ado, I think we'll just finish in here. Enjoy your lunch break and rest of the day. I think tomorrow's a public holiday. So yeah, enjoy the rest of the time off. Thank you, Junaid, again. Farwa, thank you very much. Lovely to see your little one. And Dr. Gulna, thank you very much. I don't know, Dr. Gulna, where are you located? Where are you?
I'm in Melbourne.
Oh, you're in Melbourne. Farwa is in Queensland, and Junaid is in Pakistan. I'm in Sydney. Yeah. So we're all over the shop.
Moving soon to Queensland.
Okay, yeah. Moving soon because he's got job. So you'll be working very closely with Dr. Farwa, living somewhere. Okay. All right, guys. Okay. Thank you very much.
So I have a question.
You've got a question. Let's hear
so
that
basically,
question.
I just tried to enroll in this morning clinical group. Yep. So it's been written that 120 CPD hours will be included.
Yes.
I have a big fear of my CPD hours because I'm having a clinical gap of 2 years. And now it's being said that for 1 year, you have to have 50 CPD hours if you are not going to do the residency of practice down back to your home country. So does it boost up my CV as well?
Yes. So basically, this is the whole idea. You're engaged in positive patient interaction, discussing the patient assessment, discussing the patient management. We're discussing the aspects of clinical governance. So all these CPD hour in a form of certificate will be automatically downloadable once you've completed the live sessions, plus gone through the videos of that. It'll give you on your student dashboard, download certificate. Bingo. You'll have that certificate of 120 CPD hours.
Thank you so much, sir.
All right. No problem. Any other questions? No. Good. Excellent. Thank you very much, guys. Junaid, I really appreciate you, man. Hard work. Thank you. And thank you for everyone to come and put, and yeah, excellent. Thank you very much. See you later. Bye.
Bye-bye.
Bye.